Okay, guys, this is chapter 22, the shoulder complex. So the shoulder, unlike the other joint that we discussed, it's much more complicated structure because the shoulder is not just the glenoid cavity and humeral head articulation. So it's much more than that. By me saying that is it involves the multiple structure and a multiple joint. So the shoulder complex involved the sternum, rib, clavicle, scapula, and also the humerus. So unlike other parts, we're going to spend a lot more time talking about the anatomical structure. And it is important for you to understand what is being involved when somebody's using the shoulder. So the contents of this first video is to review the bony structure that contribute to the shoulder complex and go over the bony landmarks. And I'm going to talk about joints. There are multiple joints and movement which occurs in each joint and a musculature. And in a separate video, I want to talk about nerve because the whole upper extremity is innervated by brachial plexus. So I want to go over the brachial plexus in the second video.
All right, let's review the bony structure of the shoulder complex. And as we mentioned before, shoulder complex is made out of sternum, clavicle, scapula, and humerus. Okay, so let's go through each one of them. Except for sternum, we already reviewed that in the previous chapter. So start from clavicle. Clavicle is a about 6 inches long structure, bony structure that are located on the anterior aspect of your upper shoulder area. And it has a nice S-shape structure, as you can see from the superior view. So the medially it articulate with the sternum, and laterally it articulate with the acromion, which is part of the scapula. And as I mentioned, it has this nice S-shaped curvature. And if you start from medially, it kind of curves anteriorly and then posteriorly. Okay, so we can divide clavicle into about 3 different areas. And most often, the fracture to the clavicle happens the lateral third, 1/3 of the clavicle, which is right here, because of the curve that are happening here. Clavicle has a very important function. So it protects the neurovascular bundle that are sitting right underneath the clavicle from any blunt trauma that apply to the top of the shoulder. And the other important structure of the clavicle is to provide a stability or connection for the scapula and the humerus, which attach to the axial skeleton. So the axial skeleton is the central skeleton, which include the spine and the rib and the sternum and then also the pelvis. Appendicular skeleton is your extremities. Okay, so axial skeleton is your central skeleton, the framework of your body, which provide the stability. For scapula and humerus, which creates the shoulder joint, this needs to be somehow articulate with the axial skeleton. But because of the location of the scapula and the humerus, it's kind of far away from the axial skeleton. And then the scapula, the articulation between the scapula and the rib, it's called the scapulothoracic joint, is not a true joint. So for that reason, we need the clavicle to connect this shoulder joint to the axial skeleton, which is the sternum. Okay, so this joint right here, this is called the sternoclavicular joint, also known as SC joint. This is the only direct articulation for upper extremity that are directly connecting to the axial skeleton. Make sense? Okay, so that was the clavicle. Moving on to humerus. Okay, so let's take a look at lateral view. Okay, so there are some important bony landmark, but first thing first, the humerus has a head and a neck. So this white part is called the humerus head, which articulate with the glenoid cavity that are located on the scapula. Okay, and then the neck is very short compared to the femur that we saw earlier in the hip chapter. Femur has a nice head, and then the neck, and then the body. Similar structure, except the neck is much shorter in the humerus. Okay, so some other structure that I want to mention is the greater tuberosity. So this bump right here, this is called a greater tuberosity. Okay, so this is where the 4 rotator cuff muscle, actually 3 out of 4 rotator cuff muscles inserts to. And anteriorly we have lesser tuberosity, which is where the subscapularis, which is also the one of the rotator cuff muscle, inserts to. And in between the lesser and a greater tuberosity, we have bicipital groove. Okay, so this groove right here, this is called bicipital groove. Okay, and this is where the long head of the biceps tendon runs up and then inserts to the superior labrum right here. Okay, labrum is the cartilaginous structure that deepens the glenohumeral joint cavity. Okay, so we'll talk about that when we talk about glenohumeral joint. But anyway, that's the bicipital groove. Another important structure that are located laterally is called the deltoid tuberosity. And this is where the deltoid muscle inserts to. Okay, so that is humerus. And I want to go ahead and hide the humerus so we can take a look at scapula next. So let's start from the lateral view of the scapula. And again, the scapula is a free-floating bone on the posterior aspect of your upper shoulder, upper back. And it does not have a true articulation between the rib and the scapula. Okay. However, it articulate with the acromion. The acromion articulate with the clavicle, and then the clavicle articulate with the sternum. So that's how it connects it to our central part of the body. Anyway, so the landmarks. The first of all, this nice protrusion that kind of points anteriorly. This is called a coracoid process. Coracoid process provide muscular attachment site for coracobrachialis and the short head of the biceps, not the long head. We just saw the long head, right? And then also the pec minor. Okay, so again, this is clinically important structure that you be able to palpate, and it's located right beneath the clavicle. This structure right here, this is the glenoid cavity, and this is where the humeral head sits in. And notice the size. Okay, so previously we saw the hip acetabulum. So acetabulum, it looked much more like actual fossa or cavity. That's where the femoral head, the femur, sits in, right? Compared to that, the glenoid cavity is much shallow. It doesn't even look like a cavity. It just kind of looks flat surface. And then the size of the glenoid cavity and the size of the humeral head is not matching, which we'll come back to that later. But this is the glenoid cavity. And then this border right here, this is called a lateral border, okay? And then on top, superiorly, we have the acromion, okay? And again, acromion and a clavicle articulate each other. And then notice this space right here. This is the subacromion space. Okay, so this is where the supraspinatus come out and then inserts to the greater tuberosity that we saw earlier. So that is the lateral structure. Moving on to posteriorly. So the acromion continue down and create what we call the spine of the scapula. Okay, so this is the spine. So the spine of the scapula continue down to the medial border of the scapula, and then the top portion right here, this little notch or little protrusion, is called the superior angle, and then this triangle right here, this is called the inferior angle. Okay, so the spine divides the scapula, the posterior scapula, into two areas. Okay, so this region is called the infraspinous fossa, and this is where the infraspinatus muscle sits in. And then top portion is the supraspinous fossa, and this is where the supraspinatus muscle sits in. Okay. And if I rotate just a bit to the superiorly, you see right here this notch. This is called the suprascapular notch. And this is where the suprascapular nerve comes down, provide innervation to the supraspinatus muscle here, and then wraps around, go down to innervate the infraspinatus muscle. Let's isolate the scapula. Okay, so anteriorly, the last thing that I want to mention is this fossa right here. So this is the anterior aspect of the scapula, and it's called the subscapular fossa. Okay, so this is where the subscapularis sits in. That was the important bony landmark for the shoulder complex. So let's take a look at each joint, and let's start from medially. The first joint that I want to talk about is SC joint, which is the articulation between the sternum and the clavicle. As you can see, there's a thick ligament tissue that are here, and this is the anterior sternoclavicular ligament. And there is also another one posteriorly. Okay, so this would provide the stability of that particular joint. So this joint creates 3 degrees of movement, which means that when you do shoulder abduction, bring your arm up to your head, this particular joint has to move as well. Okay, so how does it move is it goes up as you do shoulder abduction, and then when you bring your arm down, it'll come down. Okay, so that's the first degree of movement. And then also it will move, this entire clavicular will move this way or this way. Okay, so when does this happen is that when you bring your arm across your body, okay, the clavicle has to move anteriorly. Okay, so that is another movement that happens here. Okay, or when you bring your arm to your back towards your spine, and then it has to move to the back. Okay, and lastly, it has a little bit of rotation. Okay, so this way or this way. Okay, so rotational movement would occur at this SC joint. So those are the 3 movements which occur with the SC joint. And moving on to the AC joint. Okay, so here's the acromioclavicular joint, and once again, that's an articulation between the acromion and the clavicle. And of course, there's the ligament which connects the acromioclavicular joint, which is called the acromioclavicular ligament. Easy enough, right? So this particular ligament provides the stability of the joint. But in addition to that, there are 2 ligaments which provides further support. So the first one is called the trapezoid ligament, and this one is called the conoid ligament. So together, these 2 ligaments is called the cracoclavicular ligament, also known as CC ligament. Okay, so again, it has two parts, the conoid and a trapezoid. So the trapezoid has a triangle shape and it's located more laterally. And then conoid, it kind of has this cone shape, which it's kind of hard to appreciate. But if you kind of rotate, then it's actually a flat ligament. And then it kind of like rotates to create kind of like a cone shape. You see what I mean? Okay, so that's the conoid ligament. And again, these two also provides a stability of the acromioclavicular ligament, because by holding these ligament will hold the distal end of the clavicle down so that it doesn't go pop up. Okay, so again, this part, AC joint, AC ligament, and then this part's the CC ligament. Together, this is the acromioclavicular ligament. Oh, and then one thing that I forgot to mention at SC joint, both SC joint and AC joint have what we call the fibrocartilaginous disc. Much like what we saw in the knee joint as a meniscus, we have this tiny disc that are located inside of the joint. Okay, so what they do is that they provide a shock absorption when you, for example, fall outstretched hand and you're trying to catch yourself by, having your arm out and then put your entire body weight onto your upper extremity from your hand to your wrist to your elbow to your shoulder. So when the force is applied, this joint can absorb that shock. Okay, and then if that fails, then you would injure this joint. Okay, but anyway, there's the little fibrocartilaginous disc that are located inside of the joint. All right, so that was the AC joint.
Okay, so let's now talk about the third joint, which is the glenohumeral joint. The anatomy app that I use doesn't have a good structure, so I'm gonna go ahead and use the PowerPoint to explain this particular joint. So glenohumeral joint is a ball and a socket joint, just like your hip joint. However, there is the structural difference between the shoulder joint and a hip joint, which is the size of humeral head, as you can see here in this picture. It's much bigger than the glenoid cavity. And you might not be able to appreciate the actual size here, but the literature says it's actually 3 times bigger than the glenoid cavity. Okay, so that proportional differences makes this joint much more mobile, which means you can do a lot of movement with your shoulder, however, makes it unstable. Okay, so the stability of the joint is an issue, particularly with the athletes who participate in the upper extremity sports. And another important stuff that I want to mention is the humeral head is resting only on a small inferior portion of the fossa, the glenoid fossa. Okay, so this is the resting position. So meaning that when you have your arm hanging by the side, only the inferior portion is actually touching the glenoid cavity. So when this is happening, we need some sort of stability structure to maintain this particular joint to be stable. So we have both passive and active, or also known as dynamic stability structure, which will maintain this, the joint. Okay, so let's take a look at those structure. So the first is a joint capsule. Okay, so much like what we saw in the knee joint, there's a joint capsule which surrounds the entire joint. Okay, so this particular joint capsule is, it's a thin layer, and outer layer also there's a thickening portion, which is the glenohumeral ligaments. So that would also reinforce the stability of the joint. And a little bit lax or loose anteriorly and inferiorly, so that when you move your shoulder, for example, when you bring your arm up to, do a shampoo or scratch your back of your head, then, you're not too tight to do that. And then the joint capsule will allow that particular movement. And also another important fact that not many people knows is there's a suction effect, meaning that, you know, there's the negative pressure inside of this joint capsule, which allows the humeral head to be articulate and then kind of pulled up against the glenoid cavity because of the negative pressure. You know, much like one of those infomercial that, you know, you kind of suck the air, you put the futon and then suck the air out and then it kind of compresses it. Kind of similar manner, except that you don't really have a vacuum cleaner, of course, sucking the air out of your joint capsule, but there's a negative pressure inside of the joint capsule naturally that would allow your humeral head to be stable and kind of, you know, pressed against the glenoid cavity. Lastly, the size of the joint capsule is the twice of the size of the humeral head. So again, it allows a movement, but at the same time makes it stable. Another important structure is the glenohumeral ligament I briefly mentioned. So the glenohumeral ligament has three parts. The first part is the superior portion, and then there's the middle portion, and then there's the inferior portion. It kind of creates this Z shape structure right here, okay? And then also notice that there's the long head of the biceps tendon that are coming superiorly and then attached to the superior part of the labrum, which we'll discuss next. So again, this is the thickening of the capsule, but there's a weak point in between the superior and the middle glenohumeral ligament. This particular region is the it's called the foramen of Wickbrecht. I think it's a German, and I'm not sure if I'm pronouncing that correctly. But anyway, that is a gap between a superior and a middle glenohumeral ligament, and it's a weak spot. So this is where if you have an anterior dislocation of the humeral head, it poke through this particular weak spot and then just dislocate anteriorly. So this is the view, sorry, I should have mentioned that. This is the posterior view, and then you remove the humeral head. So normally the humeral head would be sitting right here, and then we are looking at the back of the shoulder joint. So the labrum is the, you know, the tissue, the connective tissue, dense connective tissue, which deepens the glenoid cavity. So the glenoid fossa, as we mentioned, is very shallow and kind of like, you know, if you play golf, the tee that you place your golf ball on top, kind of like that. So you need some sort of deepening by connective tissue for that particular joint to be more stable, which is the labrum. So labrum means lip, okay? So the lip kind of seals and then deepens the joint so that humeral head doesn't dislocate as easily as it would be without the labrum. And however, if you have joint dislocation, of course, it will damage the particular part, particularly with the anterior dislocation, which is most commonly happen direction of the dislocation. Inferior and anterior inferior portion of the labrum will be injured. And this particular region is called the Banker lesion. And later we're going to discuss, or actually maybe next week, we're going to talk about the surgical intervention to fix that particular part. Okay, so those were the passive stability structure. But the dynamic stability is maintained by the rotator cuff muscles. If you take the capital letter of each rotator cuff muscles, you can read it as a sits muscle. So that's why people call it as a sits muscle, okay? Each muscle has a different function, meaning that supraspinatus contribute to first 30 degree of abduction, and infraspinatus anterior minor contributes to the external rotation of the humerus, and subscapularis, since it inserts to the lesser cervical, or lesser tuberosity, it will do internal rotation. So each individual function of the rotator cuff is different. However, their primary function or importance, is that it would provide this, suction effect of the glenohumeral joint, meaning that because it all musculature inserts to surrounding the humeral head, it pulls the humeral head up against the glenoid fossa. Okay, so that dynamic stability is important because constantly, if you're standing up or in a daily activity, the gravity is applied, so it pulls the humerus down, right, naturally. And of course, the inferior is the most unstable location or direction of the glenohumeral joint. So with that said, these four rotator cuff muscle, it pulls the humeral head up against the glenoid fossa. So that is the providing a dynamic stability of that joint. So bursa is not contributing to the stability of the joint, but it would lessen the friction between the structure that are located around the shoulder, because it's because of the nature of kind of a lot of the structure that are located in a small space. You need lots of bursa, which reduce the friction between the structure rubbing against each other. Okay, so most notable bursa that I want you to be aware of is the subacromial bursa. So as we saw earlier, there's the acromion here, and then underneath the acromion, there's a small space where the supraspinatus tendon will come out and it inserts to the greater tuberosity. So that particular space is almost about the big, the size of your pinky. And oftentimes, if the bursa is compressed against, between the supraspinatus and acromion, the bursa could inflame. If the bursa inflamed, it kind of blows up just like a balloon, and which creates even less space underneath the acromion, which could be the cause of shoulder impingement, which we'll discuss later. Okay, so this is another important, clinically significant structure that you need to be aware of, subacromial bursa. Okay, so that was the glenohumeral joint. And I want to briefly talk about the scapulothoracic joint. Okay, again, this is not a true joint. Your SC joint, AC joint, GH joint, those are true joint, meaning that it has that, structure of the joint capsule, and then there's the fibrocartilaginous disc in between, and then there's the ligament that surrounds. Those are the normal structure of the joint. But again, this one doesn't have any of that. So its scapula is free floating up against the rib. And this picture demonstrates the resting position of the scapula. So for example, your superior angle right here is approximately about the level of T2 spinous process. And the medial border where the spine of the scapula meets, that's about the level of T3. Okay, and the inferior angle is about the T7 level. Okay, so this is the approximate location of where the scapula should be located. And from the spine, the distance from the spinous process to the medial border at the spine of the scapula level should be about 5 centimeter, okay? And to the inferior angle, it should be 10 centimeter, okay? And naturally, the scapula is already upwardly rotated about 5 to 10 degree, okay? So that is the natural, resting position of the scapula. And again, the movement of the scapula is essential for us to create the movement at the shoulder. So without that, we won't be able to have a full range of motion. That'll bring us to the next topic, which is the movement which occurred at the shoulder. Okay, so before we talk about the movement which happens at the glenohumeral joint, I want to review the movement of the scapula. So the scapula will have different movements. First, I want to talk about the elevation of the and the depression. So elevation is when you bring your shoulder up, much like when you shrug your shoulder, and depression is the opposite. So the bringing the shoulder or scapula back, down, okay? Retraction is bringing the scapula towards your spine, and protraction is bringing the scapula away from the spine, much like when you reach forward and touch something or grab something, or when you punch a wall or something, okay? So the scapula is moving away from the spine. And upward rotation, which occurs with the shoulder abduction, is when the inferior angle of the scapula will move up, okay, laterally, up and out. And then downward rotation would be the opposite of that. So the inferior angle will come down towards the spine. And one movement that it's not mentioned here is that the scapula will also tilt anteriorly, okay, or tilt posteriorly. And those movement is essential when you do flexion and extension of your shoulder. Okay, so these are scapular movement, and the muscles which complete this movement will be discussed in the muscle part that is going to be later. Okay, so now let's talk about the shoulder joint movement. Okay, so there are flexion and extension, and so the flexion and extension is happening in which plane? The flexion and extension happens at the sagittal plane, right? And flexion is about 180 degree and extension is about 60 degree, okay? But when you do these movements at the shoulder joint, what is happening to the other joint that we discussed? So for example, when you extend, go ahead and try that as you listen to this lecture, but bring your arm back. What do you think is happening to the scapula? So your scapula has to tilt anteriorly in order for you to do the extension, right? So without the scapular movement, you can only go so much of the extension, but to achieve the full range of motion, you notice the scapula is tilting anteriorly, okay? So that has to happen, and the opposite would be the flexion would be, the scapula has to posteriorly tilt. And if that happens, if the scapula is moving, what does that mean? So that means that there's a movement in the AC joint and then also the SC joint. Particularly, we talked about how clavicle moves, elevates or move anteriorly, posteriorly, or rotates, right? So with the anterior tilting of the scapula, it actually rotates the clavicle. So it creates a movement at the AC joint and the SG joint as well. So the next movement happens at the shoulder joint is internal and external rotation. Okay, so the rotational movement could happen in any, whether if it's 0 degree of a shoulder abduction, okay, so like your arm resting, okay, and the external rotation is bring your hands towards your back through the spine, and internal rotation will be the opposite, so bring your hands towards your abdomen, your belly button, okay? Or you could bring your arm up about 90 degree and then do the same thing, but except the internal rotation would be bringing your hands down, and then the external rotation is bring your hands up, much like when you high five, okay? And the other thing you can do is with the shoulder abduction, but bring your elbow forward so that it's about 90 degree flexed position. And you can do the same with the internal rotation demonstrated with the B, and then the external rotation demonstrated with as an A movement. Okay, so all of these are external rotation and internal rotation happening at the glenohumeral joint. Oh, and again, when in this middle picture, not so much movement of the scapula, but rather it's purely glenohumeral joint. And also maybe this picture right here too. But if once you bring your arm up to abduction, then that involves the movement of the scapula. Okay, we'll talk about it when we talk about abduction. But when you do internal rotation, again, the scapula has to tilt forward, and external rotation scapula has to tilt backward. So again, you know, you can't really separate the movement of the scapula and the movement at the glenohumeral joint. The next movement is the horizontal abduction and adduction. So typically abduction is when you bring your arm up, you know, towards your head, you know, from the outside. But horizontal, if you put horizontal in front, that means when you bring your arm to the side about 90 degree and bring it across your body. That's the horizontal adduction, okay? And then again, opposite would be the abduction, and you can keep going from the 0 degree farther back towards your spine. Lastly, I want to talk about abduction and adduction. Shoulder abduction, again, you know, when you bring your arm up to the side and then goes all the way up. So you can achieve 180 degree. And then adduction is opposite of that. So come down to the anatomical position and you can go further, right? So bring your hands across your body, okay? So when we talk about shoulder abduction, the important concept that I want to introduce to you is the scapulohumeral rhythm, okay? So the abduction of the shoulder is not only happening at the glenohumeral joint, but it also occurs with the scapular movement. Nothing new, right? What we talked about before. But the particular movement, understanding in which degree what structure is moving is important because, for example, if the patient has a pain or unable to complete the first 30 degree of abduction, then what's that mean? Okay, which structure is moving? Whereas if the patient cannot complete the last 20 degree of shoulder abduction, what does that mean? Okay, so initially, from 0 degree, you know, resting position to about 30 degree of shoulder abduction is only the movement happening at the glenohumeral joint, meaning that scapula is not moving at all, okay? And this particular degree of movement is complete by supraspinatus muscle, okay? Supraspinatus muscle is shoulder abductor. So when this initial 30 degree happens or conducted by supraspinatus. What happens if you have a tear in a supraspinatus? Most of the patient won't be able to initiate the shoulder abduction. So what they do is that they tilt their body, the entire trunk, like lateral bending or side bending of your trunk, so that naturally when you do that, your shoulder is about 30 degree flat, abducted, okay? So after 30 degree of shoulder abduction, the deltoid muscle will take over to complete the entire abduction, which I will mention that again in the muscular section. But because of that, you know, the patients basically cheat by side bending and not be able to use the supraspinatus, which is the essential for the first 30 degree of shoulder abduction. Okay, so anyway, so the first 30 degree is the glenohumeral joint. And then after that, from 30 degree to about 90 degrees, so the rest of the, 60 degree is the ratio of 1 to 1, okay? Meaning that scapula move 1 degree, and then the glenohumeral joint abduct 1 degree. Okay, so 1 to 1 up till 90 degree, okay? From there, so 90 degree to 180 degree, which is the rest of the 90 degree, is 2 to 1 ratio, meaning that, you move 2 degree at the glenohumeral joint and then 1 degree of the scapula, okay? So that is the detailed explanation of scapulohumeral rhythm, okay? And sometimes they just say after 30 degree is 2-to-1 ratio, but in reality, it's, once you reach the 90 degree, it's 2-to-1, but before that, it's 1-to-1 ratio. Okay, so that is the scapulohumeral rhythm, but don't forget when you do shoulder abduction, okay, so glenohumeral joint abduction is about 120 degree, but because the scapula move upward about 60 degrees, so you can achieve the 180 degree of shoulder abduction. But when you do that, don't forget that AC joint is also upward rotating about 35 degree. And then, there's a movement of the SC joint, meaning that, your clavicle has to move upward about 25 degree. So what does this mean? Okay, it's clinically important because your patient comes see you and then say, oh, I won't be able to, raise my hands, like bring my arm up. It hurts to do that. So what does that tell you? Well, first of all, is the scapula moving? Is there something wrong with the glenohumeral joint? Or is there something wrong with the AC joint or SC joint? So you need to do a full assessment of each joint in order to figure it out or get to, narrow down to the root of the problem. You can't be just looking at the glenohumeral joint and assume that the pain is coming from there, because oftentimes it might not be the cause of the injury, okay, or the pain or dysfunction. So hopefully this explained why the shoulder is complex, and it oftentimes is difficult for athletic trainer to evaluate shoulder because there are multiple factors that is involved in this particular area. Okay.
Okay, so let's begin with the movement of the scapula. So movement of the scapula, there's elevation, depression, protraction, and a retraction, and upward rotation and downward rotation. So first, let's take a look at the elevation. So elevation is when you shrug your shoulder, the scapula by itself, scapula itself will move upward, okay, go straight up. The primary mover for that is upper trap. Okay, so again, the trapezius muscle, as we saw last week, I think, has the upper and the middle and lower part. But particularly for this movement, upper trap will do the work. Okay, so this is the primary work musculature. But underneath the trapezius, we have levator scapula. Okay, so the levator scapula is another muscle which also assists the upper trap to do the scapula elevation, along with the rhomboid. Okay, so when these musculature contract, it will bring the scapula up. On the other hand, the depression will be lowering the scapula. But naturally, if you bring your scapula up, just like when you shrug, it'll come down. So the primary mover for that would be gravity. Okay, so the gravity will bring it down. But for some individual, because of if you have a tightness or imbalance in between upper and a lower trap, you need to train that specific muscle, the antagonist of the upper trap, in order for the scapula to remain in the desired position. So lower trap will definitely depress the scapula, and along with the latissimus dorsi. The latissimus dorsi, the insertion that is written on most of the textbook is the anterior aspect of the humerus. I think we saw that in a previous chapter, right? However, it also has a fascial connection on the scapula as well. If I draw it here, as you can see, this rib right here is the superior border of the latissimus dorsi, and then the scapula will come down like that. And here, there are some fascial attachment to the scapula. So because of that, I think the latissimus dorsi can also assist with the depression. Okay. Another muscle is the pec minor. Okay, so if I rotate the body and then take one layer down. Okay, so the pec minor inserts into the coracoid process, originate from rib 3 to 5, and there are actually a lot of the variation on the origin of the pec minor. So some people start from 2, 3, 4, some people do 3, 4, 5, 4, 5, 6 is less common, but I've seen it. Okay, so but my point is the insertion point is the coracoid process. So when the pec minor contract, not only it tilts the it tilts the scapula forward, but at the same time it depresses it. Okay, so that is another muscle that I want you guys to be aware of for depression. Okay, so going back to protraction. Okay, so the protraction is when the scapula move away from the spine. Okay, so just like when you do, trying to punch a wall or like, trying to reach forward to grab something, scapula has to move away from the spine and anteriorly. Okay, so the primary mover for that is the serratus anterior, which is this muscle right here. In a very fit individual with low body fat, you see this wing-looking musculature on the side, okay, on the side of the torso. So this particular muscle will originate from the ribs, okay, external surface of the 1st through 9th rib, sometimes 10th, and then it wraps around. I know it's a little bit hard to see, but it inserts to the medial border of the scapula, which is right here. Okay, so what happened is it originates from the rib anteriorly, it wraps around your rib, your torso, and then goes underneath the scapula, meaning runs anteriorly, anterior aspect of the scapula, and goes all the way and inserts to the medial border. We don't see that because, we have the scapula and then the musculature on top. But if we, look it from anteriorly, that's what is going on here. Okay. So as a result, when the muscle contracts, it pulls the scapula this way, which is the protraction. So that is the primary mover, and the retraction is the opposite of that. Okay, so moving the scapula back towards the spine. And the primary mover for that is the middle trap. Okay, so the middle fiber of the trapezius muscle will do that along with the rhomboid. Okay, and this you can see, the medial border of the scapula is the insertion for rhomboid major and a minor. So these are the musculature that will pull the scapula together to the spine. Okay, and important note here is the rhomboid originate from the spine, right? The spinous process, and it inserts to the medial border. And then, as I mentioned, the serratus anterior wraps around the torso and then originate here. Okay, so what happened is that the rhomboid and serratus, when you dissect the body, it looks like a one single muscle that are continuous. Even though it inserts from here to here, here to here, there's no really like a clear distinction here. But what does that mean? So when you look at those two musculature, okay, so the function or the action is the opposite. Serratus anterior will protract, and then rhomboids will retract, right? So these musculatures are antagonist to each other. So the perfect balance between rhomboid and a serratus is ideal, meaning that if you have a too strong serratus anterior muscle or tightness in the serratus anterior, then what's going to happen? Your scapula, again, remember, scapula is a free-floating bony structure and there is no joint. So if the serratus anterior is stronger, your scapula resting position will be moved this way, okay? And if the rhomboid is stronger, then scapula will move this way, which is a little bit less common. Okay. So again, to have a nice positioning of the scapula, the resting position, would be important for our upper extremity function. Okay. All right, so moving on to the upward rotation and the downward rotation. And upward rotation is going to be performed by upper trap, okay, and also the serratus anterior. Okay, as you saw, the serratus anterior kind of wraps around in a diagonal manner. So when they contract, it will actually bring the scapula rotate upwardly. So the importance of upward rotation is that, you know, when we bring our arm up to our head, above the head, that specific movement is not happening only at the glenohumeral joint. It happens with the conjunction of the movement between the glenohumeral joint, scapular upward rotation, and then also the little bit of movement at AC and SC joint as well. Okay, so the harmony of those four joints that I just mentioned is necessary for us to be able to bring our arm up. Okay, but with that said, the primary mover for upward rotation of the scapula is the upper trap and the serratus anterior. The other hand, the downward rotation, of course, again, similar to the depression of the scapula, it is done by gravity. But at the same time, once again, the latissimus dorsi will bring it back and down. Okay, so that will be the opposite of upward rotation. All right, so that is the basic movement of the scapula and a primary mover. Okay, so let's take a look at the movement of the glenohumeral joint. So first, let's take a look at the musculature which will do abduction, and that would be a middle deltoid. Okay, as we saw earlier with the scapulohumeral rhythm, the deltoid will complete the abduction of the humerus primarily from 30 degree to above. Okay, so 30 to 180 degree. So initially, what happened is that supraspinatus muscle, which is located much deeper, right here, it pulls the humerus in about 30 degrees. So initially, suprascapula, which inserts here, you know, the arm, this is the humeral head, is a straight down, and the supraspinatus is attached to the top, right? The deltoid, on the other hand, it attached to the deltoid tuberosity. So what happens here is that deltoid doesn't have an advantage of abducting the humerus when your arm is straight down, 0 degree. So what happens is the supraspinatus will pull the humerus just a bit from 0 degree to about 30 degree. Okay. So this first 30 degree of shoulder abduction is complete by this supraspinatus muscle, which is one of the rotator cuff muscle. Okay. So when the humerus is now at 30 degree, what happens? So the deltoid muscle that was there, now the deltoid tuberosity will be over here. So the muscle is in more ideal position, a little bit of, you know, those fibers are crossing so that the musculature will be able to contract. On the other hand, when your arm is straight down, the muscles are stretched out. So it's not in the ideal position for the deltoid to contract. But anyway, so now it is at 30 degree. So from here to all the way up at 180 degree, the middle deltoid, well, with the assistant with the anterior and the posterior deltoid, but primarily the middle deltoid will do the abduction. Okay, so those are the two primary muscle which will do the abduction. Okay, but remember, so the scapula upward rotation must happen for you to complete this particular movement, right? So the upper rotation of the scapula is important, and that movement is done by, if you can't answer this question, then go back to the video earlier and then watch it again. Okay. So that was the abduction, and adduction, oftentimes, it'll just come down with the gravity, but at the same time, we have some musculature which will conduct this specific movement, the adduction. Okay, so one of the big primary muscle is the latissimus dorsi. Latissimus dorsi is one of the most important muscle because it'll do a lot of shoulder movement along with the scapula. Okay, so the latissimus dorsi is located here, and once again, the innervation is on the anterior aspect of the humerus, specifically the floor of the bicipital groove. So if I turn it, just in case if you want to see, it's right here. Okay, so and then I don't know if I can get rid of this. There we go. So then you can see the latissimus dorsi along with the teres major that are on the little bit superior is inserting on the anterior aspect of the humerus, specifically on the floor of the bicipital groove. So what does it do when the latissimus dorsi contract? Okay, so it adducts and then of course extend and then internally rotate, right? So if I draw it, it'll pull this way and then to the back and then also internally rotate because of the insertion here, and then the origin would be here but on the back side. Okay, so what happens is it turns your arm internally. Okay. Anyway, so that was the adduction. So latissimus dorsi and teres major. But on top of that, we have one more strong muscle that are located right here, which is the pec major. Okay, so the pectoris major originate from the sternum and the clavicle, and it inserts to the similar area to the latissimus dorsi and teres major insertion. But specifically though, so let's say this is the head of humerus, and then there's this little greater tuberosity, okay, and then there's the little lesser tuberosity, and the bicipital groove is located in between, so this is the bicipital groove, right? So latissimus dorsi will come from the back and then inserts to here, okay, and then teres major will come and then inserts little medially to that. Okay, so this is the teres major and this is the latissimus dorsi. Pec major will insert most laterally and located above. Okay, so here's the insertion of the pec major. Okay, so this is the pec major that are sitting on top of the teres major and latissimus dorsi. Okay, so these three muscle actually inserts to 1, 2, 3, just like that. Okay, right next to each other. So those three will, together do the adduction. Excuse me. Okay, so that was the abduction and adduction. I want to move on to quickly talk about the flexion and extension. So flexion and extension is completed by, well, for flexion, it's the anterior deltoid. Okay, so anterior deltoid, and the pec major is the primary flexor. Okay, with a little bit of help with the biceps brachii and coracobrachialis. The coracobrachialis is tiny muscle that are located underneath the biceps brachii, and they originate from the coracoid process and inserts to the mid-humerus. Okay, so when this tiny muscle contract, it'll bring your arm up, right? The flex. Okay, so those are the four musculature that will do flexion. Okay, and at the layers back up, and the extension will be completed by the opposite of anterior deltoid, which is the posterior deltoid. And then also latissimus dorsi, as we mentioned, right? With a little bit of help with the triceps and the teres major. Okay, so the teres major and the latissimus dorsi is kind of like the combination because the function is exactly the same. Even though the latissimus dorsi is very thin, flat muscle, and it's a big muscle, and compared to that, the teres major, let's see if I can have you guys have a better look. Teres major is a smaller muscle, but the function of those two musculatures are exactly the same. So it is a little bit confusing because the name says teres major, and then as some of you might know, there's muscle called the teres minor. Okay, so oftentimes people just assume that those two muscles are similar in a function, just like we saw in the rhomboid major and a minor. But it's not. Okay, so the teres major is going to do extension and adduction and internal rotation as we saw in the latissimus dorsi. But teres minor, on the other hand, will externally rotate the humerus. Okay. All right, so those are the flexion and extension. Okay, so let's talk about the external rotation and internal rotation first. Okay, so let's talk about internal rotation because we already kind of mentioned it, some of it already. So as we said, latissimus dorsi, teres major, and I guess I didn't really mention it, but pec major also will do internal rotation, right? Just like what we saw in the adduction, you know, those three musculature that are inserting on the floor of the bicipital groove, pec major, latissimus dorsi, and the teres major. So those three muscles also will do internal rotation, okay? So those are the primary musculature, along with the subscapularis, okay? So subscapularis is located on the anterior aspect of the scapula. So I don't know if I can show you this. There we go. There. Okay, so subscapularis originate in the subscapular fossa, which we saw in the bony section, the bony landmark section, and it inserts to the lesser tuberosity, okay, which is located more anteriorly. So what happens is when this muscle contracts, it rotates the humeral head medially. Okay. So that is another muscle that are going to internally rotate the humerus. Okay, so, oh, and then there's the anterior deltoid as well. So total, let's count. So we have latissimus dorsi, teres major, pec major, those are the three muscles right here, right? And then anterior deltoid and the subscapularis. So we have a total of 5 relatively big muscle that will do the internal rotation. Okay. What about external rotation? Let's flip the body. Okay. We only have 3 muscle which will do external rotation. One of them is posterior deltoid. Okay. So it kind of like, you know, anterior deltoid will do internal rotation and a posterior deltoid do external rotation, so they kind of kill each other. So, okay, so what's the other 2? The other 2 is going to be your 2 of your rotator cuff muscle. Okay, so first one is infraspinatus, okay, and teres minor. Teres minor is really small muscle, and these 2 muscles together will do external rotation. Isn't it seem a little odd because we have 5 big internal rotation muscle, whereas they only have 2 external rotation muscle, or I guess 3 with the posterior deltoid. So as far as in terms of gross anatomy, what you see is you're going to see a thick layer of fascia which enclose these two muscles, which will do external rotation to make it a little bit stronger, right? So you don't really see the muscle fiber first. You're just gonna see this white, shiny fascial tissue on top of it. But the reason why is that most of our daily activity, I would say, does not involve the external rotation. Okay, so primary reason why we have external rotators is to stabilize the humeral head up against the glenoid cavity. So when we talk about the joint, we talked about how unequal the glenoid cavity is compared to the size of the humeral head, right? So the glenoid cavity is located like this, and a humeral head, the size of the head is 3 times bigger. It's located like that, right? So what I'm saying is that these supraspinatus, those rotator cuff muscle, the sits muscle, right? So what are those? Let's review that. The supraspinatus, which is right here, okay? And then infraspinatus, right here, so SI. And then teres minor, okay? And then subscapularis we saw over here, okay? That are inserting to the lesser tuberosity. So all together, they pull the humeral head up against glenoid cavity. Okay, so that is the primary function of these rotator cuff muscles, right? So it's not really action producing musculature. With that said, and we don't really have to do external rotation in our daily activity. If you are living, without participating in any sport, then how often do you have to do external rotation in our daily activity? So because of that, we don't have a strong external rotators, which tends to become issue if you participate in an overhead activity sport. Because what you're gonna do when you throw a ball. Okay, so when you throw a ball, what kind of movement is that? Well, first, you're gonna wind up. So you're gonna open up your shoulder, and then you externally rotate it, right? With a ball in your hand. And then as you throw, what happens? You will bring your arm forward and in sequence with the extension of the shoulder while internally rotating, right? And then maybe bring your arm forward across your body. So horizontal adduction, okay, as you extend your arm. So this whole sequence is the releasing a ball and then decelerating your arm down to, to across your body, right? So this is the internal rotation movement. Internal rotation movement is happening when, what's that mean? So the internal rotator muscles that we saw earlier, the 5 musculature, is contracting, shortening. But what's happening with the external rotator muscle? They are eccentrically contracting to control the movement, okay? So when you decelerate, the contracting muscle, the shortening muscle will bring the arm down, but at the same time, the eccentrically contracting muscle, which are specifically the infraspinatus and teres minor, are lengthening and controlling the speed of that specific movement. If they are not working together with the internal rotators, what's going to happen? Your arm's going to spin like crazy because you can't really control the movement, right? So you probably end up dislocating your shoulder. With that said, if you do large amount of overhead activity, pitching, it will place a huge stress on the external rotators. Okay, so if you have a weak external rotators, then that becomes an issue with it'll result in different types of injuries that is going to be, we're going to discuss later, maybe next week. Okay. But it's important for you to understand that, well, first of all, the movement that happening at the glenohumeral joint and which muscle is responsible for each movement, and the balance between the external rotation and internal rotation, and how it's different as far as the amount of musculature that we have available to complete that specific movement. Okay, so hopefully that makes sense. And that was the movement of glenohumeral joint.
This concludes the first part of the shoulder complex anatomy. Okay, so this is the first video of chapter 23, the elbow. And as always, we're going to start with the anatomy. So this video will talk about osteology, ligaments, muscles, and arteries and nerves in the cubital fossa and the cubital tunnel. So if you haven't watched the shoulder lectures, especially the brachial plexus video, then please do so before you watch this video. Okay, so let's begin.
All right, first let's take a look at the joints that constitute of your elbow. So there are three separate joints in the elbow. The first one is the articulation between the humerus and the ulnar, which is also known as humeral ulnar joint. And this particular joint is the primary skeletal constitution of the elbow, so that, if you look in the back, actually, the humerus and ulnar articulate, nicely to each other, compared to the radius is just kind of sitting there. Okay, so even though the humeral radial joint, which is the second joint that is between the humerus and the radius, is also part of the elbow joint, the primary bony stability is coming from the humerus and the radius. And later we're gonna see the wrist. I mean, not this week, but you appreciate how radius was small in the elbow, but once it gets to the wrist, it gets broader, and it provides a majority of the stability in this wrist joint. And then the ulna becomes much skinnier, and then there's a gap between the ulna and the carpal bones that we're going to review later. But anyway, so those are the two joints that would create a movement of flexion and extension at the elbow. And these joints are the hinge joint, which indicates that those are the only movement which occurs to the elbow. Okay, well, elbow joint. Okay, and the third joint that we're going to talk about is the proximal radial ulnar joint, which is the joint between the radius and the ulnar. Okay, and the proximal is important because one more radial ulnar joint is going to be located distally at the wrist. So make sure you put proximal to differentiate between two. Okay, so that is the third joint in your elbow. And then the movement which occurs in this joint is the supination and pronation. And you notice when you are in anatomical position, these two bones, the radius and the ulnar, are parallel to each other. However, if you pronate, so the pronation of the forearm is when you bring your hands or palms down so that the palm is facing downward. Okay, so that is when these two bones cross each other, as you can see in a little video in a corner up here. Okay, so that is the pronation. And then when you supinate completely, then once again, these two bones are parallel to each other. Okay, so these are the three different joints that constitute the elbow. Once again, flexion and extension happens with the humeral radial and the humeral ulnar joints. And then the pronation and supination occurs at the proximal radial ulnar joint. Okay, so next we're going to dive into the bony structure and some important landmark for each bony structure. So let's start with the humerus. And humerus is kind of similar to the femur as we saw in the knee. And we have two bump at the distal part of the humerus, which are also known as condyle. And then again, epicondyle is above the condyle. So it's this particular region right here is the epicondyle. And of course, we have one in a medial and a one on a lateral. So medial epicondyle and a lateral epicondyle. Again, these are two important structures where a lot of the forearm musculature originate from. So make sure you remember these, okay? And then anteriorly, we have two fossa and then two articular surfaces. Okay, so let's take a look at that. First, I want to zoom in just a bit. Okay, so you can see there's this one fossa, okay, and then second fossa. And you can tell already that once, well, this is extended position, but once you start to flex, these articular surface of the radius and ulna will come down or come up, I should say, and sit in this fossa. Okay, so this fossa is named as the radial fossa. That's easy, right? Because the radial head will come and sits in it. And this one is called the coronoid fossa. And then this particular little, the part that's sticking out, this is called the coronoid process of ulna. And so that's why this is called a coronoid fossa. Again, these two matches as you fully flexes your elbow, okay? And in addition to that, there are names for two articular surface. So right here, very distal end of the humerus, where the radial head is articulating with, this is called the capitulum. Okay, so capitulum is where the radial head articulate with. And then we also have this nice trochlea. Okay, here's capitulum. Okay. And once again, as I mentioned before, the elbow flexion and extension, the primary hinge joint is coming from the humerus and the ulnar articulation. So because we have this trochlea that are, articulating with the trochlea notch of the ulna, which we're going to see in a minute, it creates this nice smooth movement of flexion and extension. Okay. So that is it for, humerus. I want to quickly see the back, the posterior aspect of it. Okay, so I'm going to slowly turn. Okay, so here, I'm going to hide the ulnar. We have another fossa. This is important. This is also known as olecranon fossa because where the olecranon of the ulna will come and articulate with. Okay, so this is olecranon fossa. And then in fact, if you, palpate the back of your elbow, you flex your elbow and then you kind of follow this bump up, then you can feel this little depression on your own. Okay, so that is the olecranon fossa, but obviously you have the olecranon that is occupying the space. Okay, so if I replace the olecranon or the ulna, then ulna is sitting in the olecranon fossa. Okay, so here, since we are in the posterior view, we're going to move on to some structures of the ulna. So first, most distinct bump here, as you see in the bump of your elbow, this is olecranon. Okay. And we already talked about how the articulation between the humerus and the ulnar, so I'm not going to repeat myself. Okay, so go back to anterior aspect. And then maybe hide the humerus as well. Okay, so here's the ulna. Okay, so the shape is very unique, right? It has this hook. The hook, the back portion is what we saw in the olecranon earlier. Okay, so the last structure that I want to mention is the ulnar tuberosity. Ulnar tuberosity is right here. There's a little ridge. So this part, And this is where the brachialis muscle inserts too, so that is significant. Okay, so let's take a look at the radius. And radius has this nice head on the top, and which we saw where the it articulate with the humerus. And underneath we have this skinnier part. This is called the neck of the radius. Okay, and underneath the neck, we have a little bump right here. This is called a radial tuberosity. Okay. This is important structure because this is where the biceps brachii inserts to. And oftentimes people confuse that biceps inserts to ulna, but in fact it inserts to radius. Okay, so that is the basic bony structure, and I'm gonna move on to ligamentous tissue to explore here. So here's the medial aspect of the elbow. And this particular ligament, which has 3 different bands, is called the ulnar collateral ligament. Much like the medial collateral ligament on the knee, it's located on the medial side and it protects against the valgus force applied to the elbow. Okay, so there are 3 different parts, and the first part, right here, let me draw it for you. This part right here, this is called the anterior band. Okay, so anterior band is the strongest, and much weaker is the posterior and the transverse band. Okay, so the anterior and the posterior band, this is the anterior and this is the posterior, connects the humerus and the ulnar, obviously. But you have another one, this is called the transverse band. Okay, so it actually runs from one part of the ulnar to the other. Okay, so it kind of runs from the posterior where the olecranon is located and into the chronoid process. Okay, so it is kind of unique because normally ligament will connect 2 different bones, but in this case, it connects the ulna, one part of the ulna to the other part of the ulna. Okay, so once again, so this triangle shape ligament is the ulnar collateral ligament, which prevents from the valgus force. On the lateral side, you have something similar. So we have this nice triangle shape, but if I break it down, it's actually 3 different structures. So the first one, it connects the humerus to ulna. Okay, so this is called lateral ulnar collateral ligament. Okay, so it's confusing, right? Because when you say ulnar collateral ligament, then automatically think that it's located on the medial side. But in this case, because ulna is kind of sitting more on the back of your elbow, so you could actually have ligament that connects the humerus and the ulna, but located on the lateral side. Okay, but this is the part of radial collateral ligament complex. Okay, so, but once again, this is called the lateral ulnar collateral ligament right here. It's actually connected underneath this next ligament that I want to talk about. Okay, so this one, this particular ligament that shapes like a ring actually, wraps around the radial head, and this is called the annular ligament. Okay, so it's a circular ligament, and this is where the radial head is sitting inside of the ring, and then it rotates, and when you do pronation and supination. Okay, so that is the annular ligament. And then this little guy right here, this is called the connection between the humerus and the radius. So this is called the lateral or the radial collateral ligament. Okay, so these 3 structures provides stability against varus force. Okay, so that was the ligament, and now we're gonna move on to talk about musculature. So I'm gonna divide it into different movement, and first let's talk about flexion. So the elbow flexion is done by 3 different musculature, and the first one is the biceps brachii. So the biceps biceps brachii originate from the shoulder, and we already saw that short head originate from coracoid process of the scapula, and that the long head originate from the top of the labrum, the superior labrum, and they come down and inserts to the radial tuberosity. Okay, so let's see if I can isolate the biceps here. There you go. Okay, so you might be surprised, or you have this stereotype image of biceps brachii is a strong musculature in your arm, because sometimes you call it as like a gun, or like you flexes your biceps, then you have this nice mountain looking shape on your upper arm. But surprisingly, this is not the prime mover for elbow flexion. The prime mover for the elbow flexion is brachialis, which we're going to see next. So let's go back. Oh, and then the primary function of this biceps brachii is the supination. Okay, so when your forearm is slightly pronated, because right now it is supinated already, but if you pronate, then the radial tuberosity will kind of come further medially, and when you flexes, or when you contract the biceps brachii, then it'll supinate your forearm. Okay, so it's a strong supinator. So let's take a look at the brachialis. Here we go. Okay, so here's the brachialis muscle. And in reality, like if you do cadaver dissection, then biceps brachii is much thin and skinnier. And then the brachialis muscle is actually wide and thick muscle. So this particular muscle originates from the anterior aspect of the humerus, and then inserts to coracoid process and ulnar tuberosity, as we talked about before. So let's take a look, just like that. So because this muscle is a short single joint muscle, it only crosses the elbow joint. All they do is flexion of the elbow. Okay, so again, this is the primary workhorse when you do elbow flexion. Okay, so the third elbow flexor is going to be the brachioradialis, which is this muscle right here. So let me isolate here. So the brachioradialis originate from the lower part of the humerus, the lateral humerus, and then inserts at the styroid process of the radius, which is at the wrist. And this particular muscle is the strongest flexor when the forearm is in a neutral position, much like when you're grabbing a coffee mug, or some sort of handle. When you are completely supinated, which is the basically anatomical position, right? And then when you turn the palm down, which is the pronated position. So halfway in between is like the neutral position. And again, every time when you shake hands, or grab some coffee, drinking coffee, and that you're in the neutral position. And this particular muscle is most strongest or active in this particular position, and that's how we test the brachioradialis. Okay, so that was the three primary elbow flexors, and now we want to move on to the extensors. And there are only two elbow extensors, and the first one is triceps brachii. So the triceps brachii, as the name indicate, has three head, and so we have long head and lateral head, which is located more superficially, and then the medial head. So let's take a look, isolate this muscle. Ooh. Okay, so here we go. And what we are seeing right now is, the yellow highlighted area is the long head of the triceps. The long head originate from the scapula, the infraglenoid tubercle of the scapula. And then the right side is the lateral head. Okay, and then underneath that we also have a medial head, but the lateral head and the medial head both originate from the shaft of humerus. And then all three heads inserts to the olecranon of the ulna. Okay, and then this is the strong extensor, and it usually, this is the pretty much the only strong extensor, because the second muscle that we're going to see is anconeus, which is tiny muscle that are located close to the elbow joint. Okay, so with that said, let's move on to the anconeus. So anconeus is this small triangle-shaped muscle, and it originates from the posterior aspect of the lateral epicondyle of the humerus, and then inserts to the ulna shaft, much kind of closer to the olecranon. Okay, and then what they do is it assists the triceps brachii to extend the elbow. Okay, but once again, you can really see the difference between the triceps brachii and the anconeus, how the size is different. So triceps brachii will do most of the work, and then anconeus will probably have a lot of to do with the proprioception, which is the sensor, right, to detect the muscular length and then the information surrounding the joint. Now we want to move on to the pronation and the supination movement, and which musculature will do that particular movement. And the first one is the pronation. So the pronation is done by the pronator teres and the pronator quadratus. So first, let's take a look at the pronator teres. So the pronator teres is one of the muscles that originate from the medial epicondyle and inserts to the middle 1/3 of anterolateral aspect of the radius, meaning that mid radius, but it's located on the anteriorly. So what they do is when they contract, it of course pronates, right? So pronation, palm down. The other muscle that are located in a deep aspect is the pronator quadratus. There we go. So here's the pronator quadratus muscle, and it's kind of like a wristband, right? It connects the radius and the ulna together. And by contracting this musculature, the radius will move on top of the ulna, creating the pronation movement. And let's move on to the supination. And earlier, when I talk about biceps brachii, I already said that biceps brachii is a strong supinator. And along with that, we have one more supinator that are located on right here. I have to strip down some muscle to show you. Here we go. So the supinator muscle, let's isolate. Okay, it kind of wraps around the radius. So it originates both from humerus and the ulnar, and kind of wraps around the radius and then inserts to anterior medial aspect of the radius. Okay, and once this muscle contracts, obviously it'll supinate the once the pronated position would be when the radius is crossed over the ulna, but once this muscle contracts, it'll come back to supination. Okay, so that's it for the musculature of the elbow, not too bad. And I know there are a bunch of other musculature that are located on a forearm, but those are the muscle that has majority of the function is at the wrist. So I'm not going to go into too much detail right now. So make sure you know whatever the muscle that I introduced to you today. So now we have reviewed the osteology and ligamentous structure and also the musculature. Last thing I want to talk about is the arterial structure and the nerve, and along with some space that is clinically important. So the first, I want to talk about cubital fossa. So cubital fossa is a triangle-shaped structure that are located on the anterior aspect of the elbow. So cubital fossa is like a reverse triangle shape. So first connect the medial epicondyle and the lateral epicondyle, and then you have the muscular border that are the brachioradialis on the lateral side, and then pronator teres on the medial side. So this particular triangle is in front of your elbow, and it's important area because a lot of the nerve and then the arterial structures are running through it. Okay, but as you can see right now, that biceps brachii muscle is covering the particular space. So biceps brachii in this case is considered as a roof of the cubital fossa. So I'm gonna go ahead and remove biceps brachii here. Okay, so we have a much better view of the inside of the cubital fossa. And as you can see, there are several nerves that are running in front and the back of the elbow, and then the arterial supply as well. Okay, so let's take a look at the arterial supply first. So as you can see, this big artery that are coming down is the brachial artery. Okay, so the brachial artery comes down and it runs in front of the elbow. And then later, after passing through the cubital fossa, it'll divide into the ulnar and the radial artery. So the radial is this side, and then it's really hard to quick, but that is the pink highlighted artery right now is the ulnar artery. Okay, so that is happening here in front of the cubital fossa. And the next, I want to talk about the nerve, because there are several nerves that are running through. Okay, so the first one on the lateral side, we can see that radial nerve is coming down. Okay, remember the radial nerve is coming from the posterior, division of the brachial plexus, and it comes down and then be divided into the radial nerve and the axillary nerve, right? And the radial nerve runs posterior aspect of the humerus and comes down. But once it gets to the cubital fossa area or the elbow area, you can see that radial nerve is actually coming anteriorly and it runs in front of the elbow. Okay, rather than back of the elbow, it comes in front of the elbow, and then once it hits the elbow, it'll come down and innervates all the forearm extensors. Okay, so the back posterior compartment of the forearm musculature, which we'll go over next week. Okay, so the radial nerve comes down, but runs in front of the elbow. Okay, and we also have, you might wonder what this is. This is the musculocutaneous nerve, if I can highlight it right here. Okay, so musculocutaneous nerve, if you remember from brachial plexus, it pokes through the coracobrachialis and innervates the biceps brachii, brachialis, right? And then comes down and it becomes cutaneous, so inserts to the skin. So that's why it kind of disappears, and it's not the nerve it's cut off here, it's because it becomes cutaneous, so that's why it kind of disappears. Okay, so the next nerve right here is the median nerve. So median nerve is the center of the M when you draw brachial plexus. It comes down, it doesn't do anything for the upper arm, but then it runs relatively medial side of the cubital fossa and innervates all the musculature of the forearm flexors. Okay, so the pronator teres is one of them, and there are 3 other musculature that are located superficially on the medial side of the forearm. Once again, we're going to go over that in the next chapter. Okay, but what's important is that it's running in front of the elbow. Okay, and lastly is the ulnar nerve. Okay, so ulnar nerve is the only nerve that runs on the back side of the elbow. Okay, you notice that it comes from anterior side first. It's running relatively on the medial aspect of the upper arm, but then once it gets to the elbow, it'll wrap around the medial epicondyle and it runs behind it. Okay, and you can see nicely from here. Okay. you might notice by now that most of the major artery and nerves run in the flexed side of the joint, meaning that, in case of the elbow, when you flex it, then the anterior side will be scrunched together, and then the posterior side, the back side of the elbow, will get stretched out, right? In case of the knee, when you bend your knees, then anterior side is going to get stretched out, and then the posterior side will be crunched, right? Major arteries and nerve usually runs on the flexed or crunched side. Okay, so if the elbow's case, it's anterior. For the knee's case, it's posterior. And you can notice that for lower extremity, the sciatic nerve, the big nerve that are coming back, and then also even the femoral nerve and artery, which originate from the anteriorly, it'll runs to the back and then runs to the back of the knee, not the in front of the knee, because that's the extended side or stretched out side. Make sense? So the ulnar nerve is one of the few exceptions to the rule, which runs on the stretched out side of the joint. Because of the reason, it would provide it might not be a good word, but it would cause you a lot of the issues. Okay, so one of the issue would be injury to the ulnar collateral ligament, and this particular nerve is going to get irritated, okay, because of the valgus force that are, either repetitive or acute one-time valgus force is applied to the elbow, which causes not only the ulnar collateral ligament, but also the ulnar nerve will be damaged as well. So one of the procedures that they do is to move the ulnar nerve anteriorly, kind of by the medial nerve, so that it wouldn't cause you much issue later on. Okay. But anyway, this particular area is also known as cubital tunnel. Don't get confused. There's a cubital fossa, which is on the anterior aspect of the elbow, and then the cubital tunnel, which is the medial aspect of the elbow, where ulnar nerve is enclosed within that specific tunnel. And we'll talk more about that in the injury section. So anyway, but that is what I wanted to show you in the anatomy of the elbow, and that pretty much conclude everything. Okay, so in this video, we're gonna go over brachial plexus. Brachial plexus is the collection of anterior rami of the spinal nerve level from C5 through T1. Okay, so these plexus creates complex pathway of the nerve that combine together and then separate branches off, and in the end it'll innervates the entire upper extremity, both sensory and motor and reflex. There is one exception to that I want to mention initially, is going to be the trapezius. So all the musculature that I covered in the previous video is innervated by brachial plexus, except for trapezius. Trapezius has a cranial nerve innervation, so cranial nerve 11, which is the spinal accessory nerve, innervates the trapezius. So that would be the only exception, and everything else will be innervated by brachial plexus, as we are going to look at it first. Okay. Well, before we get to that though, I want to show you how each spinal nerve root comes out of the intervertebral foramen, and it creates the brachial plexus. So I put a label for each vertebrae and the level. So here's the C5. Okay, so as we mentioned in the spine chapter, this particular nerve that come above the C5 vertebrae is going to be the C5 spinal nerve root. Okay, so this is the C6, C7, and then underneath the C7 there's going to be spinal nerve C8. And remember, for the cervical region, the spinal nerve root come above the vertebrae, right? The corresponding vertebrae. So this is going to be C4, C3, C2, okay? So, but since in the thoracic region, the spinal nerve root come out below the corresponding vertebrae, so which allow us to have extra nerve between C7 and T1. So that is going to be C8 spinal nerve root right here, okay? But don't get confused, there's only 7 vertebrae in the cervical. And T1, this is the T1 spinal nerve root, create the brachial plexus. Okay, so if you follow and turn this model here, then you see this nice bundles of nerves that are becoming kind of combined together, and then goes all the way down to innervate everything for upper extremity. Next, I want to show you how to draw a brachial plexus. So I want you guys to take a piece of paper and a pen and draw this nice schematic of vertebral body from C5 through T1 and the spinal nerve root that are coming out of between each vertebrae. So first step of drawing a brachial plexus is to draw 3 Ys. So alphabet Y. So the first Y connects the C5 and C6 nerve root and then goes all the way down. The second Y connects the C8 and T1 spinal nerve root and connect all the way down. The third Y is a little bit smaller and reversed direction. So go ahead and draw extension of C7, and in the end, a small Y is going to be drawn. So that is the first step. And the second step, I want you to draw 2 M that are rotated laterally. Okay, so the first M is going to be in the end. Okay, the second M is going to be about here in the middle. So that's the second step. The third step is going to be crossing the only top portion of the more proximal M. And that's it. Lastly, I want to draw some branches. The first one is draw a tail off of the first M that we draw. And second, there's going to be one right off of the C5, 2 from 5 and 6, and 1 here, 3 here, 3 here. And lastly, there's long thoracic nerve that are coming from 5, 6, 7 and coming down all the way. This completes the drawing of brachial plexus, and if I expect you to practice a couple times to memorize how to draw. Once you finish drawing a brachial plexus, let's divide the brachial plexus into 5 different sections. So the first section right here, this is called the root, okay? And the second section is trunk, division, cord, and terminal branches. And these are, you can memorize it by real trainer drink cold beer. Okay, so that's how I remember. But anyway, the root represent each spinal nerve root, and trunk represent these 3 different branches that are, so the superior branch right here, and this is the combination of C5 and C6. Middle is only C7, and inferior represents C8 and T1. Okay, so this is the trunk, and in the trunk we have a few branches that are coming off, which we'll talk about it later. Okay, and next is the division, and this is when the so brachial plexus branches, it comes out as a superior, middle, and an inferior trunk. They divided into anterior division and a posterior division. So first, this is these 2 that are become together, which is the anterior division, and the one that are coming from C8 and T1, there's going to be another anterior division. Okay, so whatever that nerve that is coming from this anterior division will run in front of humerus and innervates the musculature and the skin on the anterior region. On the other hand, these three nerves that becomes together, all of them is the posterior division. Okay, so obviously this is written on a piece of paper, so it's two-dimensionally, but if you think about it as a three-dimensionally, this will go into the back and innervates all the musculature on the posterior compartment. Okay, so now you see the how the anterior is popping out and the posterior is going deeper. Okay, and in the cord, of course, this cord is named as the posterior cord, but the anterior cord has two, so further named it as lateral cord and medial cord. But again, these are in the anterior in relation to the posterior cord. And lastly, we have terminal branches. So let's review those branches. Okay, so I want to go from the end. So the musculocutaneous, median, ulna, these are the three nerves that are innervating the musculature and the skin on the anterior aspect of your upper arm and a forearm and the hand, right? So musculocutaneous, particularly, it'll come down and poke through coracobrachialis muscle, innervates that muscle, and also biceps brachii and brachialis. Median nerve, on the other hand, it's in the middle and it doesn't really do much on the upper arm, but once it gets to the forearm, they innervate the forearm flexor, the wrist flexors. And also has a small innervation to the thenar muscle, which is the musculature in your hand, which creates the movement of your thumb. Okay, so the thumb, okay. Okay, so the ulnar nerve is going to be innervating a few muscle in your forearm. It's located on the ulnar side, which I'm not going to go through right now. We're going to talk about it later in the forearm or the elbow chapter. And majority of the hand. Okay, so most of the hand, the intrinsic muscle is innervated by ulnar nerve. So here's the anterior division. Okay. In a posterior cord, we have axillary nerve. Axillary nerve goes to the back and innervates teres minor and also the deltoid. Okay, and radial nerve innervates lots of muscle, but primary it innervates the triceps brachii in the upper arm, comes down and innervates the forearm extensors. It's in the posterior compartment. So these 5 nerves are terminal branches of brachial plexus, but we want to rewind and go back and see the small branches right off of the trunks and the cord section of the brachial plexus. So first of all, this little nub that are right off of the C5, this is called the dorsal scapula. Dorsal scapular nerve innervates the levator scapula and rhomboid minor and major, and those 3 musculature together will do scapula elevation. And the next one right here is the suprascapular nerve. And we saw in the bony landmark section of the previous video that there's a suprascapular notch, and that's where the suprascapular nerve comes around and then innervates the supraspinatus, wraps around the spine of the scapula, and innervates the infraspinatus. Okay, so that's the suprascapula that are off of C5 and C6. And right here, there's the nerve to subclavius. Subclavius muscle is, we haven't really saw it yet, but it stabilizes the clavicle and located directly underneath the clavicle. It's a tiny muscle, but it's important to provide a stability of clavicle during the upper extremity movement. And this long nerve, this is called a long thoracic nerve, originating from C5, C6, C7, innervates the serratus anterior. Okay, so the serratus anterior's function is not only to create scapular protrusion, but also protraction. I'm sorry, but also it holds the scapula against the rib. Okay, so it is running fairly anteriorly on the lateral surface, the mid-axillary line, and during the removal of breast tissue for the patients with the breast cancer, oftentimes this nerve is in danger of getting, cut. So surgeons pay particular attention to that location of the specific nerve so that they don't injure long thoracic nerve. If they did injure the long thoracic nerve, the serratus anterior is no longer working properly. So what happened is the condition called winging of the scapula. Winging of the scapula is when the medial border of the scapula pop up. Okay, so it resembles the look of wing. So that's why we call it as a winged scapula. Okay, due to the lost function of long thoracic nerve. Okay, so that is that. And then moving on to, there's no branches off of the anterior and a posterior division. But once we get to the cord, we have 7 branches. So off of the lateral cord, we have lateral pectoral nerve. Lateral pectoral nerve innervates the pec major. And off of the medial cord, we also have medial pectoral nerve. So these two nerves, you should memorize it together, and they both innervates the pec major. Okay. Medial pectoral nerve also innervates pec minor. So what you're going to see is you're going to see this particular nerve poking through the pec minor muscle and it innervates the pec major. Okay. And these little 2 branches off of the medial cord is the cutaneous nerve, medial cutaneous nerve of the arm and the forearm. The one closer to the medial pectoral nerve is going to the arm, and then the one further from the medial pectoral nerve is going to the forearm. So these are cutaneous nerve, meaning that they don't innervate the muscle, but they provide sensory innervation to your skin, particularly on the medial aspect of your arm and the forearm. Okay, so last 3 right here off of the posterior cord is the upper subscapular nerve, and then the furthest right is lower subscapular nerve. And these two both innervates the subscapularis muscle, but at the same time, the lower subscapularis also innervates the teres major. Okay. The last one in the middle, this is thoracodorsal nerve innervating the latissimus dorsi. So again, all the musculature that have function to the scapula and the shoulder and upper arm, everything in the upper extremity is going to be innervated by brachial plexus. And a primary function of the reason why we create this complex brachial plexus is because when the injury happens to one single nerve root level, the extent of loss of function is going to be minimized because of this brachial plexus. For example, if you have injury to the C5, let's say right here, okay, most of the nerve, for example, like suprascapular nerve that are innervating the supraspinatus and the infraspinatus, still get innervation from C6, okay, because C6 is okay, right? So even though you lose C5, you still have a C6 that are covering for C5, okay? So this whole thing is to protect our musculature and a sensory innervation when the injury happens to one specific nerve root, okay? You might lose dorsoscapular nerve, but dorsoscapular nerve, I believe it has some innervation from a little bit higher than brachial plexus, like C4. So that way we don't completely, the muscle is going to be weaker, but we don't really lose the function completely. Now let's go back to the model and then appreciate based on what you just drew on a 2D paper. Okay, so here we have C5, C6 making a superior trunk, C7 is the middle trunk, 8 and T1 is the inferior trunk. Now notice that you coming out, these three different trunks that are coming out laterally, and then next step it would be to divide the anterior and a posterior division. Okay, so if I turn this model slightly, then you can see right here, this is the anterior division. Okay, and then this is the posterior division. And I know it's kind of bunched up, so it might be hard to see, but this is the first M that we draw, right? And then you can kind of appreciate how the anterior division is coming anteriorly, and then the posterior division is going posteriorly. And then off of the lateral cord that we saw, this particular nerve would be lateral pectoral nerve right here. Okay. And then this is the medial pectoral nerve. So now you can appreciate how lateral and the medial pectoral nerve, they both, it's each originating from a different cord, lateral cord and a medial cord, but it'll come medially and it innervates the pectoris major. And particularly for the medial pectoral nerve, a minor as well. Okay. And I'm not going to go into all of the detail, but I want to show you the second M that we draw. Here's the median nerve, okay? And then this is the musculocutaneous nerve. And then this is the ulnar nerve. So I know it's not completely M right here, but if you turn it just a bit, it kind of resembles the M that we draw. And again, those are the anterior portion of the brachial plexus terminal branches. And posteriorly, we have, radial nerve, there we go, that runs down all the way to the, goes down posteriorly and then innervates triceps brachii, okay. And then also the axillary nerve, that's one of the terminal branch, and then of course it'll wrap around and innervates the teres minor and the deltoid. Okay, so it might look overwhelming, but you might have to go back and forth between the drawing and remembering the musculature, and then also go back to the 3D images of the muscles with the nerve, and then appreciate how the brachial plexus runs.
This concludes the lecture about brachial plexus, and please review and make sure you know how to draw brachial plexus. So last week we started talking about chapter 24 from forearm and then into the wrist, and this chapter, or it's actually the same 24 chapter, but we're gonna continue to talk about more detail of our hand and a finger. And this video primarily focus on the anatomy. And first, as always, we're gonna go over some joints and the bony skeletal structures, and then move on to the musculature. And then lastly, we want to talk about extensor expansion, which is kind of unique structure on your finger, the back of your finger. And lastly, conclude with the neurological innervation of our hand.
All right, so let's talk about joints in our hands. Okay, so the first joint that I want to talk about is the carpal metacarpal joint. As the name suggests, it's a junction between the carpal bones and the metacarpals, okay? So if you look at the first metacarpal right here, it's the junction between the trapezium, which is this one, and the first metacarpal. And for the second, trapezoid and second, and then we have capitate and a third and a fourth, a little bit of fourth, and we have a hamate between the fourth and fifth. Okay, so this particular joint is called a carpal metacarpal joint. Okay. From second through fifth carpal metacarpal joints, these are plain type of synovial joint, which means there's almost no movement occurring in this particular region. Okay. However, first carpal metacarpal joint is different from the rest of the carpal metacarpal joint. In that first carpal metacarpal joint, as I zoom in, is rotated about 90 degrees. So here, if I do this, you see the second through fifth metacarpals are lining right next to each other like a parallel manner. Compared to that, we have the first metacarpal joint facing this way, okay, instead of this way. Okay, so this angle makes something unique in this particular first carpal metacarpal joint. This first carpal metacarpal joint is actually not a plain joint. It is a saddle joint. Okay, so you can see the shape is different as well. That would allow us to create a movement of flexion and extension, a abduction, a deduction, and also a movement what we call the opposition. This is very special to the thumb. Okay, so we'll take a look at each movement here that's happening at first carpal metacarpal joint. And the first movement is the flexion and an extension. Okay, as you see in this corner, the flexion and extension, when you think about flexion and extension of the elbow, knee, usually occurs on a sagittal plane. Sagittal plane is the plane that bisects your body into right and left, right? So whenever the flexion and extension happening, it's happening on the sagittal plane. However, this flexion and extension happening at the first carpal metacarpal joint is on the frontal plane because of the 90-degree rotated positioning that we just saw. Okay, so don't get confused when you say flexion and extension of the first carpal metacarpal joint. It does not happen on a sagittal plane, but instead it'll happen on a frontal plane. Okay, the opposite would be true for abduction and adduction. Abduction and adduction of the shoulder normally happen on a frontal plane, right? The frontal plane is the plane that bisects your body into anterior and a posterior, front and a back. In this region on the thumb, the abduction and adduction happen on a sagittal plane. So flexion and extension, abduction and adduction is opposite, happening on the opposite compared to the rest of our body. Okay. The last movement is opposition. Okay, so opposition is rotation of first metacarpal against the trapezium as you bring your thumb, the tip of the thumb and the pinky together. Okay, so this particular movement allow us to do a lot of the fine, delicate movement of the thumb, and including the precise gripping of a pen as we, write something on a paper. Okay. So that three movement happens on this first carpal metacarpal joint. So moving on to the metacarpal phalange joint. Okay, so these are the metacarpal phalange joint, and as the name suggests, it's between the metacarpal and phalanx, the proximal phalanx, right? And these joints are condyloid joint, meaning that there's flexion and extension, and abduction and adduction occurs in this particular joint. Okay, so in our hand, the middle finger, the third finger, is the axis of movement. So when I say abduction, it's away from this middle finger. So the second and fourth and fifth fingers are moving away from the third finger. The opposite, this is the abduction. Okay, my pen is not working really good today, but a deduction is when these other fingers are coming together towards the middle finger. Okay, anyway, you get the idea. I can't really draw here. Oh, there you go. Okay, so that is abduction and adduction happening at the metacarpal phalange joint. Okay. And lastly, we have interphalange joint. For our thumb, we only have proximal and distal phalanx, so that's why we only have one IP joint. But however, for the rest of the finger, we have proximal and distal interphalange joint. So here's the proximal, okay, and then here's the distal, okay. And these are hinge joint, okay, much like what we saw in the elbow. It only does flexion and extension, okay. So there's that. And next section, we're going to talk about muscles. So here's the surface anatomy that you can, take a look at your own hand and then make sure where the location for each joint is. So from DIP, PIP, MCP, which is basically your knuckles. And then the CMC joint is actually located in way further proximal in our hands. So if I remove the skin, then you can kind of refer where the joint is located. Okay, so I want to start out with talking about musculature that are related to thumb movement. The first movement that I want to talk about is flexion, okay? So there are two muscles that will complete the movement of thumb flexion. And the first one we already saw in the previous lecture is the flexor pollicis longus, okay? So the flexor pollicis longus is this yellow highlighted muscles that are located in the deepest layer of your anterior forearm. So this is considered as an extrinsic muscle, which will have action of thumb flexion in our hands. Okay, in fact, this muscle inserts to the distal phalanx of your thumb, so it'll flex at CMC joint, metacarpal phalange joint, and even at the IP joint as well. Okay. The other little muscle that you're seeing is the flexor pollicis brevis, okay? And the name is very similar, but the end is different, the longus versus brevis. The brevis means short, so it indicates this is the intrinsic muscle. It originates from the flexor retinaculum of your hand and then inserts to the proximal phalanx, okay? So this particular muscle does not have an action at the IP joint, but rather it'll create the flexion of CMC joint and then the metacarpal phalange joint. The next movement that I want to talk about is abduction. Okay, so abduction, as we mentioned already, happening on the sagittal plane. So it'll look like this, right? So if I rotate, looking from the lateral side, it's lifting up your thumb up so that it's happening on a sagittal plane. So what muscle would do this movement? Okay, extrinsic muscle we saw earlier is the abductor pollicis longus, which is this bigger muscle that are located on a forearm. Okay, this is located on the posterior extensor side of your forearm and then inserts to the first metacarpal. Okay, once again, it'll create abduction of the movement, and this particular tendon creates lateral border of your anatomical snuff box. Okay, and along with that, we have abductor pollicis brevis. Okay, much like what we saw with the flexors, similar, right? So these two muscles together will create the abduction of your thumb. So here we have opponens pollicis, which is this little muscle in your thumb. Okay, so the opposition is a movement when you bring your thumb and pinky together. Okay, so this particular movement is complete by only the intrinsic muscle, so the opponens pollicis. And later we see opponens digiti minimi, which is located in the pinky side, work together to bring the fifth finger along with the thumb coming together to complete this opposition movement. So here, to summarize, this is the most superficial layer, abductor pollicis brevis. And then what's underneath is the flexor pollicis brevis. And then if I remove one layer, two layer, then you see opponens pollicis. These three musculatures are intrinsic muscle that are located in your thenar eminence. So the thenar eminence is this little, bump on the bottom of your palm on the thumb side, and within here you have all those three muscles that has function of your thumb. Okay. And in addition to that, deeper, we have what we call the adductor pollicis. Okay, so the adductor pollicis has two head, the transverse head and then oblique head. So I'm gonna remove these connective tissue so that you can take a look at that in a better view. So here's the oblique head, and then here's the transverse head. Okay. These two together will create a deduction movement. Okay, we don't really have extrinsic muscle, which helps us to do adduction of our thumb. Okay, so only intrinsic muscle. So the first one is adductor pollicis, as we saw. And the second muscle, which will help us do the adduction of our thumb, is going to be the first dorsal interosseous. Okay, which is this one. So this particular muscle originate from the lateral, the medial aspect of the first metacarpal, and it pulls the first metacarpal towards the second. Okay, so which is basically the movement of adduction, right? So this particular muscle and the adductor will complete the adduction movement. So the last movement of the thumb is going to be extension. So the extension of the thumb, which is on the frontal plane, is complete by three extrinsic muscles. So we don't really have an intrinsic muscle for this. So the three musculatures are what we saw in the previous lecture, which is the extensor pollicis longus, extensor pollicis brevis, and abductor pollicis longus. So these three muscles that we're seeing right now is going to create what we call the anatomical snuff box. Okay, so now we talked about the movement of the thumb and associated musculature. We're going to talk about muscles which create a movement of our second through fifth finger. Once again, the carpal metacarpal joint of the second through fifth is immobile or minimum movement, so we don't really have much going on there. But for metacarpal phalange joint, we have flexion and extension, and an abduction and an adduction. So first muscle that I want to introduce you is lumbrical. Okay, so the lumbrical is going to create flexion at MCP joint. At the same time, it'll also extend the phalange joint, both PIP and a DIP phalange joint, which we'll see that later. Okay, so but this particular muscle originate from a tendon, the flexor digitorum profundus tendon. Flexor digitorum profundus muscle originate from the deepest layer of your anterior forearm, and then the tendon comes down and it inserts to the distal phalanx, as we can see right here. And the lumbrical originate from the tendon and then inserts to the lateral or the side of the proximal phalanx. Okay, so what they do is it flexes at the MCP joint, as you can see in this movement here. Okay, so as the lumbrical contract, it'll create this flexion at MCP joint at the knuckle. Okay, but what's interesting is that the insertion point is blended with the extensor expansion. Okay, so extensor expansion hood is this structure, connective tissue structure on the posterior or dorsal aspect of your fingers. And then since it is connected to that extension expansion, contraction of the lumbrical muscle will leads to the extension of distal and proximal interphalange joint, which we'll talk about talk about it more in details later when we talk about extensor expansion. So let's talk about adduction. The finger adduction happens at metacarpophalangeal joint and complete by palmar interosseous muscle. Okay, so palmar interosseous only has 3 muscle belly, and it's between fourth and a fifth finger, third and a fourth finger, and a second and the third finger. Okay. Now there's the adductor pollicis that are right in front of the palmar interosseous. But this particular muscle will do adduction. So from, when the fingers are spread out, it pulls the finger together. So all the fingers are kind of like, aligned right next to each other, because of this particular muscles are pulling the second into third and the fourth and fifth into third. Remember, the third is going to be the axial or the axis of this movement. So these other 3 fingers are kind of moving towards the third finger, the middle finger. Okay, how come we don't have 4? How come we don't have one that the first metacarpal joint moving towards the third joint? Because we do that movement, right? But the particular movement of adduction is actually completed by the adductor pollicis, what we saw earlier, the transverse and oblique head. So because of that reason, we don't really have palmar interosseous muscle that are between first and second. Okay, so what's opposite of adduction would be abduction, right? So the movement of abduction has, I would say, 2 parts. So the first part would be second, fourth, and fifth fingers are moving away from the third finger, but the middle finger could also move side to side towards the second finger or the fourth finger. So those movement is considered as abduction, and that particular movement is complete by dorsal interosseous. Okay, so dorsal interosseous has 4 heads, and there's 1 head that are between first and second finger, okay, which is highlighted in yellow. And then there's second head and the third head on the either side of the third metacarpal. Okay, so because we have these heads, we can move our middle finger side to side. Okay, and lastly, we have this one between fourth and fifth, which moves the fourth finger away from the third. Okay. And lastly, how do we move our pinky away from the third? We don't really have dorsal interosseous for that, but instead we have abductor digiti minimi brevis. Okay, so this little guy, the little muscle that are on the pinky side is not part of the dorsal interosseous. It's an independent muscle, abductor digiti minimi. And the abductor digiti minimi will pull the fifth finger away from the third, which assists this, completes the, the movement of the finger abduction. Earlier, we saw abductor pollicis brevis, so we have something similar on the thumb side, which will allow us to do abduction of the thumb. So the last set of muscles that I want to talk about is the hypothenar musculature. So as we saw in a thenar eminence, we also have a hypothenar eminence, which is this area of, the bottom of the pinky. So in here, we have 3 major muscles. The first one is already what we saw earlier, is the abductor digiti minimi. Okay, so the abductor digiti minimi abducts the fifth finger. Okay, and if I hide this particular muscle, what we see underneath here is the flexor digiti minimi. Okay, so the flexor digiti minimi flexes the fifth finger at MCP joint. And what's underneath that would be opponent's digiti minimi. Okay, and this is what you need in order to complete the opposition movement when you bring your thumb and a pinky together. So we have exactly the same set of same set of musculature on the hypothenar and the thenar eminence. Okay, so once again, we have abductor, okay, whether if it's pollicis brevis or digiti minimi. We have flexor and then opponents. So those are the 3 same set that we have on both sides, the thenar or hypothenar side of the hands. Okay, so that would complete the musculature of our hand.
Okay, in this next section, I want to spend some time talk about this triangular aponeurosis that are located on the back of your finger. This is called the extensor expansion hood, sometimes just the extensor hood. And what it is that recall that we saw earlier, or not today, but last week, we saw some extensor digitorum tendon that are going into each of our finger. And then also particularly for index finger, we have extensor indicis. For pinky finger, we have extensor digiti minimi tendon. Okay, so those tendons are actually going to insert to this triangular aponeurosis, which is the connective tissue. And then what happened is that as those muscles contract, it will not only extend at a singular joint, but rather it'll kind of have this harmony of extension at DIP and a PIP and also metacarpophalangeal joint. So the contraction of the extensor tendon will allow us to extend all the way at each joint. That's why we don't really have a separate muscle like what we saw earlier with the flexor digitorum profundus and the superficialis, how superficialis only goes to the middle and then the profundus goes to the distal. Okay, so this is a hood mechanism which allow us to do a full extension of our finger. What's related to that is this lumbrical muscle. Okay, so the lumbrical muscle, as we saw earlier, it originates from flexor digitorum profundus tendon and it inserts to this extensor hood on the lateral aspect. So notice that lumbrical muscle comes from the back and then inserts here. And then here's the axis of the MCP joint. So as the lumbrical flexes or contract, it will create flexion at MCP joint because, imagine pulling this tendon down will, bend the MCP joint. But since it's connected to the extensor hood, as the lumbrical contract, it will contract the extensor hood, which means that your distal and the proximal interphalangeal joint will go into extension. I hope that makes sense what I just said. So as a result, you have this D movement where the flexion of MCP joint and extension of PIP and a DIP joint, which resemble the shape of alphabet Z as you do it with your arm. The other connective tissue structure that I want to mention here is the pulley system. So for extensor hood system is on the dorsal aspect of your finger, but then palmar aspect has connective tissue that would prevent the bowstringing of flexor digitorum profundus and a superficial muscle, okay, or tendon, as I should say. So those two tendons are going to come down and it inserts to either the middle phalanx or the distal phalanx, right? So as they come down, in order for you to flexes those fingers at PIP or DIP joint, those tendon has to be attached to the bony structure. So what we have here is here's the tendon, and then there's the tenosynovium sheet that are surrounding the tendon. And in this each area from A1 through A5, it has this pulley system that would, make sure these tendons are kind of attached to the bony structure and not getting a bowstring. So the last part of the lecture, I want to talk about nerves and innervation and conclude this lecture. So first part is the sensory innervation. So this diagram here is showing which nerve is innervating which part of the skin in your hands. As you can see, the blue is ulnar nerve, which innervates the skin over your hyperthenar, and then also the fifth finger and the medial half of your ring finger. Okay, and then the green part is the radial nerve innervation. This is only the dorsal aspect of your hands, particularly from the thumb to the middle finger and half of the ring finger, but particularly the tip of those fingers are innervated by median nerve. Okay, so the pink region is the median nerve sensory innervation region. So this, if you notice, then as you evaluate an injury with specific tingling or abnormal sensation or paresthesia, then you know which nerve is the one that's getting involved with that particular injury. And for the motor innervation, this should be slightly reviewed. The median nerve comes down as a terminal branch of the brachial plexus and innervates most of the forearm flexors, right? And then also there's a little tiny branch that are after passing the carpal tunnel, they provide innervation to the thinner musculature that we talked about in the thinner eminence, including the abductor pollicis brevis and a flexor pollicis brevis and an opponent pollicis. Okay, one to note here is the adductor pollicis is not innervated by median nerve, even though it is located kind of closer towards the thinner eminence. The adductor pollicis is innervated by ulnar nerve. And the other muscles that in your hands that are innervated by the median nerve is the first and second lumbrical muscle. Okay, so those are the things that you should be aware of because it's important when you think about injuries. And here's the motor innervation of ulnar nerve. And once again, similarly to the median nerve, ulnar nerve is a terminal branch of brachial plexus, and it comes down, doesn't do anything in the upper arm, and there's a little bit of innervation in the forearm, particularly the flexor carpi ulnaris, and then also medial half of the flexor digitorum profundus. But the majority of ulnar nerve function is in your hands. So those tiny intrinsic muscles that we just talked about, majority of them are innervated by ulnar nerve. The exceptions we already saw in the median nerve. Okay, so the radial nerve doesn't do anything as far as the motor innervation in your hands. So the ulnar nerve provides most of the innervation to the muscles in your hands. So as I mentioned, the radial nerve really doesn't have motor innervation in your hands, but also, it'll provide a sensory innervation to the back of our hands, as we saw earlier. Okay, so this would conclude the innervation, the sensory innervation and the motor innervation of the hands. And to understand that would assist us to evaluate a specific injury, particularly related to neurological functions. So in the second half of the lecture, we'll talk about some of the injury that could happen to our hands. Hi guys, this is part 1 video for chapter 24, the forearm, the wrist, and the hand. And your book covers the entire thing, but I've decided to divide it into over 2 weeks. And this week, primarily, we focus on the forearm and the wrist. So this video will talk about the anatomy of forearm and the wrist, but since a lot of the musculatures are related to your hands, so we're gonna go over that as well. Okay, so this video, the contents include the bony skeleton first. We talk about the ulnar radius and the hands, and some ligamentous structure that are mostly at the wrist. And muscles, we're going to focus on the extrinsic here, and intrinsic muscle within your hands, we're going to introduce it to you next week. And lastly, the last part of the video, we'll be talking about the nerve of forearm.
Okay, so let's review the bony structure of the forearm and the hand. We already reviewed the proximal end of ulna and a radius. If you haven't watched the anatomy video of the elbow, please do so before you proceed here. So I would like to focus on the distal end of ulna and a radius, but before we do that, I want to introduce this connective tissue structure that connects to long bones here. Okay, so this is the interosseous membrane that are connecting ulna and a radius. And much like what we saw in the lower extremity with the tibia and a fibula, they're kind of bound together. But the only exception here is that tibia and a fibula doesn't overlap each other. But since for upper extremity, we are able to do supination and pronation, and particularly when you do pronation, these two bones are gonna kind of create an X-shape format that, you know, it'll cross over. Okay, but anyway, structurally it's very similar. Okay, so moving on to the distal end of radius and ulna, notice how radius now became much wider. So here's the radius, right? Because it's on the thumb side, on the lateral side, and then here's the ulna. in the elbow, ulna had this big hook, the olecranon in the back, and then it was much bigger compared to the radial head, but that relationship is reversed here. The radius becomes big and wide, and then the ulna is much smaller. And then notice that the distance, or the ulna doesn't come far down as much as the radius. So radius, in fact, will provide a primary stability of your wrist joint, because ulna there's a huge gap between the end of the ulna and then these little carpal bones. Okay. One important structure that I want to mention here is the styloid process. Okay. So on each end, even with the radial, and then the ulna end, this little nub here, these are called the styloid processes. Okay, so they're both styloid process, and then either on a radius or ulna. Okay, and the other thing is the articulation between here. I mean, this is the distal radial ulnar joint. There's a little notch on the ulna. It's called the ulnar notch, where the head of not the head of radius, but the head of the ulna is this part right here, and then in here there's a little notch for the radius to sit in. Okay. So that's about it for the distal end, and I'm gonna move on to talk about the carpal bones. Okay, right here. So we have a total of 8 carpal bones, and then it's usually divided by proximal row and then the distal row. Okay, so the proximal row is these 4 bones. Okay, so let's go over each one of them. So the first one right here is the scaphoid. Okay, so the scaphoid is located on the lateral side of proximal row. Okay, and then right next to it is the lunate. Okay, so lunate, if you can take a look at the left corner right here, it has looks like a little half moon shape. So because of that reason, it's called a lunate bone. Okay, and then right next to lunate is actually what we call the triquetrum. Okay, notice that if I move around, triquetrum is actually only the bottom part of the carpal bone, and then these are actually 2 separate bones, and then what's sitting on top of it is called the pisiform. Okay, and if you actually trying to find the styloid process first, and then on the ulnar side, move your finger up distally, actually towards your pinky, then you feel this little bony protrusion, and that is your not piriformis, pisiform. Okay, and if you put your hands on the floor or on a hard surface, that particular bone will hit against the floor. Okay. Okay, moving on to the distal row. So the most laterally we have trapezium. Trapezium is the bony structure that articulate with the metacarpal, first metacarpal. Okay. And then right next to that we have trapezoid. And this trapezium and a trapezoid, the name is kind of confusing. You just have to memorize them. And what we have is capitate. And then lastly, hamate. Okay, so hamate, the shape is very unique. And if I rotate, it has a little handle or knob that are sticking upward. Okay, so that particular area is called the hook of hamate. Okay, this area. Okay, so once you find the pisiform, this one right here, yeah, pisiform, and then move your finger not straight up but slightly laterally, about 45 degree, you should be able to feel a hook of hamate. Okay, so those are the 8 carpal bones that are located in your hands. And once again, please make a note that the wrist articulation is between the radius and scaphoid, and then also the lunate. Okay, so these three makes up your wrist. It's not the entire proximal row of carpals, because here we have a huge, this area is an open space. But because we have this, we have a much greater motion when we do ulnar deviation, which is, if you are in the anatomical position, bring your pinky towards your body, okay? So that movement is much bigger compared to the opposite way. Bring your, pointing your toes, pointing your fingers away from your body, okay? So because of that space right here, okay? And then this become clinically important because injury could happen to this particular region, but I just leave it at that right now. Okay, so that is your carpal bones, and then moving on distally. So we have, much like in our feet, we have metacarpal, okay? So first, second, and third, fourth, fifth. And then, again, it's kind of like your foot. We have phalanx, right? And then the proximal and middle, and then distal. For second through fifth fingers, we have 3. But for your thumb, you only have proximal and distal. Okay, so the joint name is similar to the foot as well. From distally, here we have DIP joint, and then we have PIP joint, okay, and then this is metacarpal phalange joint, so MCP joint, and then here this is the carpal metacarpal joint. Okay. All right. So that's about the structure that I want to introduce. And is there anything else? Oh, this little guy right here, we also have a sesamoid bones, much like what we saw at the bottom of our feet, and that are located on the first metacarpal. Okay, so let's go over some ligaments. And the hands are much like feet, since it's being created by tiny bones. Lots of ligament has to be present, like in between each bony structure. And then obviously I don't expect you to know all of it, but here I'm gonna go over the major ones so that it's more relevant to injury that we're gonna talk about. Well, for your wrist, first of all, I want to mention these 2 collateral ligament. Okay, so much like what we saw in the elbow, we have 2 collateral ligament, and the first one is the radial collateral ligament, okay, that are located on the lateral side. If I rotate the structure, it's not that strong structure, and you could actually sprain this particular ligament, okay. And on the other hand, other side, we have ulnar collateral ligament of the wrist joint. Okay, so when you say ulnar collateral ligament, then it's confusing because you don't know if you're talking about the elbow or the wrist. So oftentimes a lot of people say MCL, the medial collateral ligament. Okay, but still, yeah, you have to clarify because there's a lot of medial collateral ligament as well. Okay, so that is 2 collateral ligament that I want to make sure that you know. And as you see in here, there are a lot of ligaments and you might be freaking out, but it's okay. There's only a handful structure that I expect you to know. And one of them is this guy right here, the piezohamate ligament, okay? So as we mentioned earlier, the pisiform is protruding anteriorly. So if I try to rotate here, you notice that piezohamate ligament will create this nice tunnel between the pisiform and then a hook of hamate. Okay, so these 2 protrusions that are on the medial aspect of your palm has this ligament over it and then create a tunnel. Okay, so we're gonna talk about later what is running through it, but if I briefly say it, that it's ulnar nerve and artery. Okay, here maybe I can show that to you. just like that. Okay. Well, in fact, it's actually underneath the ligament, but this is the ulnar nerve. Okay. And that becomes significant because if you have an injury to this particular area, then you are most likely to be, injuring ulnar nerve, the distal end of the ulnar nerve as well. Okay. So moving on, I'm going to add one more layer. That didn't do much. There we go. So the other structure that I want to mention here is the flexor retinaculum. Okay. And hand, we're going to see a lot of tendon that are originate from the forearm and then coming into the hands to create motion of your fingers, right? And much like the feet, the bulk of the musculatures are located on a forearm. And if you look at it, inside of the hands, there are only a handful of intrinsic muscle that will do a fine movement. But the bigger motion or strong motion is controlled by the extrinsic musculature. Extrinsic muscles, again, it's the definition of it is originate from somewhere outside. In this case, it's a forearm, and then originate into the hand. Okay. Intrinsic, on the other hand, it originates and inserts within the hands. Okay. So because of that, numerous tendon that are running from the forearm coming into the hands, we need some sort of structure that holds the tendon down, because otherwise mechanically it's not advantageous to have all these tendon that are running from far away and then it's just loose. Okay, so we need something that holds the tendon down, and then this flexor retinaculum particularly creates another tunnel, a bigger tunnel actually, on the palmar aspect of the hand. Okay, and this is important because particularly this tunnel is called a carpal tunnel, which is famous, right? I'm sure you've heard of carpal tunnel syndrome. If you are using a computer or on the keyboard typing and putting a lot of pressure in this particular region, you're going to compress this structure that's inside of the carpal tunnel, okay? Which we're going to talk about it in the next section, okay? Okay, so that is carpal tunnel, or the flexor retinaculum. And let's see, I want to add one more layer. There we go. Okay, so the other structure that I want to mention is the fibrous sheet. So as I mentioned, same thing here. There's a long tendon. This particular tendon is the one of the flexor digitorum tendon. Okay, so you have flexor digitorum profundus and then flexor digitorum superficialis. I'll introduce it to you in a muscle section. But these tendon has to, in order for them to flexes the finger, it has to be, tightly attached to the phalanges, right? And these tissue, okay, or these X1 is the cruciform part of the fibrous sheet, and then the circular one is the annular part of the fibrous sheet. But anyway, these fibrous sheet holds the tendon down so that it's closely attached to the phalanges. Okay, and trigger finger is another injury that is relevant here, but just remember there is a structure that surrounds the tendon for now. All right. Okay, lastly, we have palmar carpal ligament, and it's similar to flexor retinaculum that are located a little deeper, but the palmar carpal ligaments holds every tendon that are running underneath. Okay, so it's not just a single or it's not just a certain structure that is holding down as we saw in a flexor retinaculum, but palmar ligament or palmar carpal ligament holds everything that's running underneath down. Okay, so we have something similar on the other side actually, if I could flip it nicely. There we go. Okay, so this is the extensor retinaculum. Okay, so extensor retinaculum holds all the tendon that are running on the back side of your hands. Okay, so don't get confused with the name because the extensor side only has one, and then on the palmar side we have that and then the retinaculum. Okay, so it's multi-level actually. And lastly, most superficially, of course, is the palmar aponeurosis. Okay, remember we talked about with the Tommy John surgery, we have the palmaris longus muscle that are inserting into the palmar aponeurosis. Okay, so this is what I was talking about. So it's a very thick connective tissue, much like what we saw in the plantar fascia, that expands on the palmar aspect of your hands. Okay, so that's it for ligaments, and now let's move on to the muscles. Okay, so let's review the musculatures on your forearm, and then first let's review on the palmar or the anterior aspect, and then we're gonna move on to the posterior aspect. Anterior aspect, there are 3 layers. So the first layer has 4 musculature. Okay, so the first one is the pronator teres. We saw this muscle already in the elbow section, so if you haven't watched that video, please review that in there. Okay. So right after these pronator teres, or before actually, these 4 muscles that I mentioned, it all originate from the medial epicondyle. Okay. So if I rotate right here, you can appreciate how these 4 muscles that are originate from the same common origin. Okay. So moving on after the pronator teres, what we have is flexor carpi radialis. Okay. And my advice to you, if you want to memorize these muscles, is because, the name indicates the location and then where it goes to. Okay, so particularly with the flexor carpi radialis, because it's, it goes to the thumb, which is most lateral structure, so it has to come first. So like the flexor carpi instead of ulnaris, which we're gonna see later, the radialis come first. Okay, so and then carpi means carpals, right? Obviously, and then it goes to the radial side. Specifically, it goes to the base of 2nd and the 3rd metacarpal. Okay. What does it do? It flexes your wrist. Okay, and then also assist with the radial deviation. The next muscle here is palmaris longus. Okay, and as I mentioned before, 20% of the population is missing. Okay, so to know if you have it, we checked it already, so I'm sure you already know if you have palmaris longus or not. Okay, inserts to the palmar aponeurosis, and then the only function this guy has is the flexion of the wrist. Okay, moving on. The last of the 4 is the flexor carpi ulnaris. Okay, so once again, it's on the ulnar side, so it makes sense, right? And this one, it inserts to pisiform, hook of hamate, and then the base of 5th metacarpal. Okay, so kind of has a multiple insertion. Let's isolate and take a look at it. It doesn't really show on this structure, but it'll insert not just the hamate, but also on a pisiform. Okay, the hook of hamate part is not showing here, or the base of the 5th. Okay. All right, so those are the 4 superficial musculature, and you can memorize it by placing your hands on a medial, actually placing your thumb on a medial epicondyle, and then if you lay your fingers on the anterior aspect of the forearm, then you can, try to memorize the index finger is a pronator teres, and the middle finger is, flexor carpi radialis and such. Okay. Okay, so let's go deeper. Okay, so that was the superficial layer, and the intermediate layer, we only have 1 muscle. okay, so which is flexor digitorum superficialis, okay. When you say digitorum, flexor digitorum, what does it mean? It flexes your fingers, right? And this is the same with the foot. And same here, but except we have two separate digitorum. One is superficialis, the other one is profundus, which we haven't seen yet. Okay, so the superficialis, as the name indicates, it's more superficial compared to profundus. And the insertion point is different, okay? So I'm gonna zoom in here, okay? Superficialis inserts to the middle phalange, and as they do, they split to two different tendon and it inserts to the middle phalange, okay? So do they have a function at the distal end? Are they able to flexes at the DIP joint? No, okay, because it only goes to here. They can do PIP joint flexion, but they cannot do DIP flexion. Then who does the DIP flexion? This guy right here is the flexor digitorum profundus that we're gonna see in a third layer, okay? But anyway, so this muscle is actually pretty strong though, flexor digitorum superficialis. It has a very broad origin, okay? It originates from medial epicondyle of the humerus, and then also has a little bit of ulnar and a radius origin as well, okay? So that was the flexor digitorum superficialis, and let's get rid of that. And to move on the deepest layer, so here we have flexor digitorum profundus, and the flexor digitorum profundus originate from the medial aspect of coronoid process of ulna, and it comes down and splits into four and inserts to each finger at distal phalange this time, okay? So this particular muscle is, allow us to be able to bend our finger at the very tip of it at the DIP joint. And of course, it'll do a flexion at PIP joint and also the metacarpal phalange joint as well here, okay? So that is the deepest layer, one of the muscles in the deepest layers, and what's right next to it is the flexor pollicis longus muscle. Okay, so pollicis is thumb, okay? So this particular muscle originate from the radius and then inserts to the distal phalange of the thumb, okay? And if, of course, as the name indicates, it flexes the thumb. And we already saw, did we see this before? Can't remember if I showed this to you, but I think I did. But anyway, the last muscle that I want to talk about on the anterior aspect is the pronator quadratus. Okay, much like the pronator teres, this particular muscle will create a pronation movement. It connects the radius and the ulna at the distal end. Okay, so moving on to the extensor side or the posterior side, and to orient ourselves, here's the triceps brachii and then anconeus muscle that we saw earlier. And most of these superficial extensor muscles are originating from the lateral epicondyle. So I'm gonna rotate this model just a bit so that you can see all of the musculature. The first muscle is actually not originating from the lateral epicondyle, is the brachioradialis. And in the elbow chapter, we saw this muscle. It assists with the elbow flexion, and particularly most active when the thumb is pointing up, right? So right underneath that, here we have the extensor carpi radialis longus. Okay, make sure you remember the whole entire name. And this particular muscle originates from the supracondylar ridge, meaning that not the epicondyle, the lateral epicondyle, but slightly above that. Okay, and notice that there's the flexor side. We have flexor carpi radialis, and that's it, right? But it's actually extensor carpi radialis longus, meaning that there's the brevis, the shorter version of it. So here we have the longus. It inserts to the dorsal aspect of the base of second metacarpal. Okay. And slightly inferior to that, we have the extensor carpi radialis brevis. Okay, so they're right next to each other, and they basically have exact the same function, but insertion point is a little bit different. The longus inserts to the base of second, and then the brevis inserts to base of third. Okay, let's see if I can show you that. Just like that, you see. Okay, so both of these muscles extend at the wrist, and then also does the radial deviation. Okay, so moving on to the next muscle is the extensor digitorum. That's it. No superficialis, profundus, or longus. It's just the extensor digitorum. It originates from the lateral epicondyle and then comes down, inserts to second through fifth digits. Okay. And what does it do? It extends the fingers. Okay, so last muscle in the superficial layer is the extensor carpi ulnaris. Okay, no longus brevis because there's only one. This particular muscle inserts to the medial aspect of the base of the fifth, okay? And then when this muscle contracts, it'll produce a movement of wrist extension and then also ulnar deviation. All right, so that was the superficial muscle, okay? Next, I want to introduce you to outcropping muscles. Okay, so the outcropping muscles are the ones that goes to your thumb, and then it produce a movement at the thumb, but it originates from the posterior aspect of your forearm. Okay, and then kind of wraps around and comes down to the thumb. And the first one here is the abductor pollicis longus, and that one is the most. It located most, I would say, laterally, okay? And then right next to that, we have the extensor pollicis brevis that are running kind of along with the abductor pollicis, okay? Longus. And then it inserts to the proximal phalange of your thumb. And one more right here that are kind of not running parallel to the last two muscles that we just saw is the extensor pollicis longus. Okay, so this one inserts to the distal phalange of the thumb, and then it extends the thumb. Okay, so these three muscles, okay, extensor pollicis longus, brevis, and abductor pollicis longus. This muscle comes down and it inserts to the thumb, and then what's important here is that it creates what we call the anatomical snuff box. Okay, so this triangle area right here. Okay, so this is the anatomical snuff box. Okay, I want you to try on yourself to extend your thumb or like bring your thumb up. Much like, you know, when you're trying to shake somebody's hand, and then bring your thumb all the way up, and then you notice there's a little dimple on the bottom of the thumb. That's your anatomical snuff box, okay? And what's important is this is the, important landmark to find a scaphoid carpal bones. Okay, sometimes in the fracture of the scapula, people will complain of a point tenderness right in the anatomical snuff box, okay? And not just that, we also have the radial artery that are running inside of here, okay? So you could actually try to take a pulse if you wish, and then find the radial artery in here, okay? Okay, so that is the anatomical snuff box. And going back to muscles, okay? Whoa. I want to strip down some more muscle to get to the deeper layer here. Okay. So here we have a supinator muscle. I wonder if I could go one more down. There we go. Okay, so that is located in the deepest layer, okay? And we saw this already in the elbow section. So we also have extensor indicis muscle. Remember, we have extensor digitorum, which goes to the index finger as well. But extensor indicis is specifically just going to the index finger and extends the index finger. And we also have one for pinky finger, the extensor digiti minimi muscle. Okay, so this is also the deeper layer that you need to know. Okay, I think this concludes the muscular portion of this lecture. Okay, so the last section of the video, let's talk about the neurological, the nerve of the forearm and the hands. Okay, so in the brachioplexus video, we saw the terminal branches of the arm or the brachioplexus, including a median nerve, and then the radial nerve we saw in the elbow that are coming down on the anterior aspect, and then ulnar nerve that are running behind the medial epicondyle and comes down and innervates all the muscles. Okay, so median nerve, let's start with the median nerve we see here, running on a medial aspect of the cubital fossa, and then it comes down, innervates all these forearm flexors, what we saw in the superficial layers, and then intermediate layer and a deep layer. There are some exceptions though. So the first exception would be the flexor carpi ulnaris. This is innervated by ulnar nerve, okay, which we see right here. There we go. Ulnar nerve. And then also the flexor digitorum profundus, which only half of it, on the medial half of it, is innervated by ulnar nerve. With that minor exception, the median nerve actually innervates most of the musculature on the anterior aspect. Okay, the radial nerve on the other side. Okay, this nerve innervates majority of the posterior aspect of the muscle that we just saw. The ulnar nerve, what does it do? Does it only innervate the flexor carpi ulnaris and the flexor digitorum profundus, half of it? No, it comes down, and then as on a medial aspect here, this is the ulnar nerve, and ulnar nerve provides innervation to majority of the intrinsic muscle of the hand, which we haven't really talked about it, but I'm saving that for next week. Okay, so it kind of has a separate roles, right? In general, median nerve does the forearm flexors, radial nerve does the forearm extensors, and the ulnar nerve does the hands. Okay, but I want to mention the course of how these nerves run, particularly in the median nerve. Okay, so here's the zoom in version of your wrist, and here's what we saw, the palmar carpal ligament earlier, and what's underneath is all of the tendon that are originate from the forearm coming into the hands, right? And if I rotate just a bit, okay, and here we saw flexor retinaculum. Okay, so whatever the structure that are running above, it's fine. It's not going to get compressed, because look at the space we have between the flexor retinaculum and then palmar carpal ligament. Okay, so I want to go deeper. So if I remove some of the structure, okay, there we go. Okay, so here we have a better look of flexor retinaculum. Okay, so what is underneath the flexor retinaculum? So we have, what is this tendon right here? Okay, so this is the flexor digitorum superficialis. Remember that intermediate layer muscle? And then it inserts to the middle phalange. Okay, that's running underneath the flexor digitorum, flexor retinaculum, also known as the space as the carpal tunnel. Okay, and then you notice there's another tendon that are running. Those are profundus. Okay, So how many tendons do we have? Even though they're originating from this common sheath, right? But we have 2 on each finger, so that means not counting the thumb, right? Obviously. So we have 8 tendons that are running, okay, in the carpal tunnel. And we have one more actually. The last one is the flexor pollicis longus, remember, in a deep layer. So that makes the 9 tendons that are inside of the flexor retinaculum. Got it? Okay, so another structure is the median nerve. Okay, and you might wonder what is this nerve that are running on top? This is also part of the median nerve, but median nerve split into the superficial layer, the palmar branch, and then the deeper layer. Okay, so this deeper layer is in danger of being compressed because of such a small space in a tunnel, carpal tunnel, and then 9 other tendons are running with it. Okay. And flexor retinaculum is very, very tight, and it doesn't have any property of stretching out. So it's very thick, inflexible structure. So if you have some sort of inflammation going on underneath, then it'll definitely compress the median nerve. Okay, so that is called the carpal tunnel syndrome. Okay, so that is the carpal tunnel. Okay. The radial nerve comes down and then innervates all the cutaneous structure on the back of the hand, but does not do any innervation on the hand intrinsic muscle. And the ulnar nerve innervation to specific intrinsic musculatures will be go over in next week.
Okay, so this concludes the first part of the video, and the second part, as always, we're gonna go over some injuries.